Okay, we're now live on the YouTube. You can start, Councillor Kitterick.
Okay, welcome to this meeting of Leicestershire, Leicester and Rutland Health Overview and Scrutiny Committee. My name is Patrick Kitterick and I am the Vice Chair of the committee, and we're currently having a few technical difficulties, so hopefully Councillor Dr. Kevin Feltham can join us and take over the chairing of the meeting in good time. I have got the agenda in front of me, so question number 1 is question time. Ewan, if you wish to call each of the people who've submitted a question to read out the question and then receive.
So there was 5 questions from the public from 3 people. They've all been circulated by email and published on the website. There were some supplementary questions. I understand Sally Wan wanted to ask a supplementary on question number 1. So, Sally, do you want to ask your supplementary now?
Yes, thank you. And thank you, Chair. I'd like to thank Chairman Feltham for his response to my initial question, which was trying to get some clarification around the additional beds. This is a question about the consultation, the Building Better Hospitals consultation, and the promised additional 139 beds. That has helped very much actually to clarify that 28 of these beds are not additional beds, they are the reuse of existing beds. So that's very helpful because it helps me to see that the number of additional beds will be 111 maximum. And my supplementary question was, where will the 70 contingent beds go? I realise that, you know, some of those might be efficiencies, but where, if we need those 70 contingent beds, where will they go? Because I'm aware that the Royal Infirmary is very full at the moment, and I think the Clinical Senate made a reference to the fact that 2,048 beds seem to be the maximum that UHL could accommodate. So it'd be useful to know where they're going. I think it's about two and a half wards full of beds. And also with regard to the 41 beds and the conversion of non-clinical space into clinical space for those 41 beds, is that work funded through the £450 million capital funding which we're getting from the government? Thank you very much.
Have we got a response for that?
Normally the response comes from the chair, and as the reconfiguration colleagues from NHS are not on the line till later, we might have to answer that question later in the meeting.
Are you okay? Are you okay to hang on, Sally, for that?
Thank you. Well, thank you, Chair. I will come in at that point of the meeting. Thank you.
Yeah, well, it's not the normal procedure. Normally the questioner asks their question during the question time item, and then that's the only part of the meeting that they're allowed to be involved in. So yeah,
I think people have often commented to me that I'm not quite normal. So it's a case of in chairing the meeting, if Councillor Dr. Feltham rejoins the meeting and takes over the chair, that'd be his approach. My approach would be that, to be frank, we're trying to encourage participation from members of the public, and certainly it seems a bit disjointed for somebody to ask a question when the person who is giving the answer isn't in the room, and then say, oh yeah, we'll answer it 2 hours later. So I think we probably need to look at how that's structured. But if we can move on to the second question.
Yeah, the next supplementary question was from Juliana Foster.
Okay. Oh, good morning. Thanks very much for allowing me to add a supplementary question. My question is, thanks for the answer that I was previously given, but my supplementary question is, who will be conducting these telephone interviews and focus groups? Will they be people working in local CCGs or UHL, or will they be independent researchers?
Ewan, is it the same format? The people who are answering?
That's right,
yeah. Okay. Well, let's move on. And again, when I do the handover to Councillor Dr. Feltham, it will be a case of we'll need to sort this out. It is a bit odd that that the people aren't here to answer the supplementaries, but I appreciate they've got pressing time. Okay, if we can move on to the third question then, please.
Okay.
Yes, this is sorry, yeah.
Go on, Ewan, sorry.
No, sorry, yeah. Second question from Juliana Foster.
Right, and this is, again, a supplementary question to question 3. I understand, thank you, Chair, that it was a full and good reply that I was given. However, you have not answered my question, which is about independence of analysis. Midlands and Lancashire Commissioning Support Unit is a paid contractor to local C. I don't see how they are independent. Please, could you tell me?
I can't tell you as I have no answer in front of me, but I'm sure we will have the people who can eventually. My apologies.
Thank you.
So can we move on to the next question?
Yeah, the next question is from Penny Campling.
Hello. Yes, the reason for asking my question about the ethics of discharging people off the waiting list for psychotherapy is that I'm hearing about people who've been through a detailed psychotherapy assessment, waited for over a year, and then just received a letter saying they're being discharged back to the care of their GP. So could you clarify, when you say in your answer, discuss and jointly agree, whether this includes the service user and whether the service user will actually be given a choice to wait for the original therapy that they were promised?
Is there anybody from the CCG and the Partnership Trust to pick up those questions?
We've got Gordon King and John Edwards on the line.
So John Edwards can pick this one up and add some detail to that original answer.
Thank you, Penny. Number one, I'm not aware of us discharging anybody as you described, so we'll look into that, Penny, because I'm certainly not aware that's practice. It's certainly not practice that we've initiated. So it'd be something that we'll review to make sure that isn't actually happening in the manner that you described. In terms of the involvement of the service user in both coming to a view on what the best option for them is, including the potential to wait, yes, I think is the answer to your question. They'll be given a full set of options. It's inevitably complicated as we're changing our services, but we want to make sure that we're making the best decisions with the patients themselves on the options that are available to them. In full recognition that the wait for therapies that is currently there is very unsatisfactory, and you know that will be a big concern to some of the service users and carers.
Thank you.
Penny, are you happy with that response?
Yeah, I think that if it's going to be reviewed, that would be good.
Okay, and Gordon, do you have anything to add?
No, just to thank Penny for her question, very helpful.
Okay, just to let members know that Councillor Dr. Feltham has now joined the meeting, but my reign of tyranny can only continue until the end of this particular item, when you'll be back in the capable hands of Councillor Feltham. Ewan, have we got? We've got some more. We've got, is it one or two more questions?
No, that's it. We've covered them all now.
Okay. Yeah, I must say, I do find it slightly odd that people ask questions and then the people aren't there to answer it. I appreciate they've got their personal arrangements and work commitments are quite pressing, but it just does seem slightly oddly disjointed, and hope that we can reconnect it when we come under the UHLCCG items. Okay, I will then pass over to Councillor Dr. Feltham to pick up the chair, and item 2, questions asked by members. Do you want to take over, Kevin?
Thanks very much, Patrick. Yeah, that's very good. Yeah, technology. It's great, isn't it, when it works? And I was only complaining last week, to someone, why can't you sort all this technology? All you members that can't seem to make it work. There you go. Pride before a fall. So questions. There were no questions from members. Item 3, urgent items. I've not been notified of any urgent items. 4, declaration of interest. Members, anybody have any interest they wish to declare? Gazing everybody.
I have no declarations, just in terms of attendance, just to pass on the apologies of Councillor Chamond, who has got work commitments. Yeah. And I'm not quite sure whether Councillor March has made it into the meeting, but she was experiencing technical difficulties getting into the meeting. So if somebody at committee services can try and assist her, that would be greatly appreciated.
Yeah, well, I in the end had to restart the whole computer, but it's obviously worked, so that's brilliant. Thanks very much.
Chair?
Yeah.
Do I have to declare the fact that I was a inpatient and also outpatient with Leicestershire psychiatric services in the previous decade, before we talk about the reconfiguration?
Yeah, I can't see that being an issue. I think your experience may well come in handy. I think from that point of view, because I mean, I used to work. I worked at Leicester Royal Infirmary 25 years ago, but I'm not going to declare that. Yes, sorry.
Sorry, Chair. Just I'm not 100% sure. Apologies, I should have asked you in advance. I work for Advanced Housing and Support, which is a organisation that provides housing for people with learning disabilities in my work life. So just in case that's seen as a declaration, I put it forward. Thank you, Chair.
Thanks, Amanda. Anybody else? No, thank you. 5, presentation of petitions. We received no petitions in time to be considered under this particular item, Standing Order 35. We did receive a representation from the public, which we're going to consider under agenda item 9 when it comes up later. But I mean, essentially, we're not considering the petition as such, because I said it came too late. But many of the points that are raised in it, everyone of the members of the committee should have had a copy. It may well be that members may well wish to raise some of the points that they've raised in their petition. Welcome, Melissa. I see you've joined us.
I have had some choice words with my computer this morning, Chair.
Yeah,
apologies for being late.
Yeah. I've roundly rebuked mine, I assure you. So we'd like to move on, therefore, to agenda item 6, which is the first major item we've got on today's agenda, Step Up to Great Mental Health, by the Leicestershire Partnership NHS Trust. For those who've got the pack, it's on pages 5 to 28. And I understand that there are a number of people from the LPT going to speak to us, but I was given the message that Gordon King and Paula Vaughan may well wish to start it off. But please do speak when you wish to.
Thank you, Chair. If it's okay, I'm Gordon King, Director of Mental Health for LPT, and if it's okay, I'll pick up agenda item 6, which is Step Up to Great, and then I think Paula's going to come in at a later agenda item. So first of all, thank you very much for a further opportunity, really, to bring this committee the progress and the next steps with our transformation of adult and older people's mental health services. This committee has previously received updates and presentations on the challenges and the relatively weak position in Leicester and Leicestershire and Rutland compared to other systems. And we've also provided updates to this committee on some of the plans as they develop. And I think the committee made a very reasonable challenge, a very helpful challenge to say, we want you to bring some pace and clarity to these plans, and also to make sure that they're linked in with best national investment to address the issues, which I think are well known to people, and we can perhaps pick them out. I don't intend to go through this paper in detail, Chair, because hopefully people have had a chance to see it, and also because I'm mindful of timing on the agenda.
Yeah.
But if it's okay, I will go through and just pick out some of the key themes, I think, and the key points within this, so that hopefully it makes a bit of sense to people. Step Up to Great Mental Health is the STP plan, is the Leicester, Leicestershire and Rutland plan. That's our transformation plan. It works, just saying very briefly, there are 4 elements to that. And whilst today, for this paper, it effectively addresses integrated community services and urgent and emergency care, it's really important that colleagues know, and this committee knows, that the work on neighbourhoods is also underway and is an extremely important part of this work. The work stream Getting Help in Neighbourhoods is really focused on making sure that we've got good engagement with PCNs, local authorities, and there's some pathfinders that are alluded to in the paper that people may want to look at, and indeed if they wish more information on that, to contact us and we'll be happy to do that. And also inpatients. Now, inpatient care is a very significant point of improvement. It's not the purposes to go through that today for this paper, but just to let the committee know that we are doing a great deal of work, and we've been successful in driving down out of area placements, which I know this committee's been concerned about. And since February of this year, we haven't placed anybody in a bed, in a mental health bed, acute bed, outside of the system, which is relatively unusual for mental health trusts at the moment, given the pressures we're under. But for the purposes of this paper, it's effectively around integrated care and urgent care. I won't go into the detail around the background, but part 6 talks about the long history of this and the detailed stages that have been gone through, and you'll see, hopefully, if you've seen the paper, the large number of service users and partners who've been engaged in this, from the VCS, local authorities, service users and carers, and the number of workshops that have been involved. So a great deal of work's gone into this over a great period of time, and also a great deal of benchmarking with some of the national best practice. Section 7, which I won't go through, but it's very helpful for people to look at, is, I think, a relatively clearly laid out table that describes the feedback and then reads across to how that's addressed in our plans. And for the ease of committee's understanding and to aid all of us, it's split into, in a sense, a patient journey. So it starts at access and works through assessment, treatment, and indeed discharge. And hopefully the committee will find that helpful. And there's more detail in the appendices. So just a little bit of information around progress since the last discussion with the committee. So a short review was commissioned, and the review, and indeed this committee, charged us with making sure that we drew this up into a coherent programme of change, and that there was clear governance on this through the STP. We've obviously followed that, and we're also working towards a clinical senate. So there's some information then in section 9 around governance, which I think is relatively straightforward. I'm happy to take further questions on that, of course, if people wish to know more. I think there's probably a couple of things that are really worth pointing out, Chair, on this, that the mental health investment standards, for people who aren't necessarily over the detail on that, is relatively recent process, and it's actually really important that this is almost a ring fence, but a very dedicated investment sum of money for mental health services as a system. And we've worked really well as a system this year to develop plans that support this transformation plan, support Step Up to Great, and deliver quite a considerable amount of investment for us to do this. So this is actually quite a good story for once. It's a story of investment and an opportunity to genuinely make a real change and improvement to services, which I think this committee would agree is long overdue. A little bit on the clinical senate. So on the 2nd of October, our service plans were subject to a detailed review by the East Midlands Clinical Senate, and colleagues probably know that provides a very independent external validation, and I won't go through the detail because we're waiting for the formal feedback, but so far the feedback has been that this was a very compelling vision, very positive, coherent plans, and they welcome particularly the strength of our co-production approach, and that's something that we're very keen on developing further, which effectively means working strongly in partnership with service users and carers to make sure that they're equal partners in delivering the changes that we need. A few comments about some of the temporary changes that we've made. because going back to table 7, some of those things are actually in place already. We've actually developed them in response to COVID. 2 of them may be of interest to the committee, Central Access Point and the Urgent Care Hub. The Urgent Care Hub is a service based at the Bradgate, which effectively allows for people to be diverted from A&E and get care without having to go through the A&E liaison service, to reduce the pressure and flow on UHL through COVID, which has been very, very well received by service users and carers, and the evaluation of that's quite strong, overwhelmingly positive. In fact, we've got more work to do on further evaluation. And then crucially, the central access point. Now, this is interesting to this committee because I think in this system there's been a perfectly legitimate criticism of the complexities of our systems, and particularly in terms of urgent care and the real complex nature of how people can access urgent care in a timely fashion. So the central access point, which was opened in April, for the first time provides open access, self-referral directly into LPT. And the principles of this are there's no such thing as a bad referral, and there's no wrong door. So rather than expecting people to make rather complex journeys around primary care to make sure that they can get a referral, they can actually refer themselves directly. And then we will work with them in partnership to make sure that they get the services they need in a more timely fashion. And if that doesn't necessarily, as probably around 50% of it doesn't fit neatly within secondary mental health care, that's fine, because we can still work with service users to support them in how we can develop services with them, and obviously that will develop through our neighbourhood plans. That's been overwhelmingly received by our service users and by partners. So the key thing about both of those is we really want to make sure that we invest further in those and make those sustainable, because the feedback on both of those developments has been extremely strong. So very, very briefly then, the proposed urgent and emergency care improvements are really about continuing that work that we've started. So we've got a number of different touch points of community and crisis care in the system. We want to make sure that they work better together, that we've got stronger management over them, and that they work as one seamless pathway. We've done a great deal of work on that. So that basically means when people need urgent crisis healthcare, that they can get it in a much more reasonable and less complex way. And as I say, the no wrong door approach, I think, underpins that really. So we're going to continue to work with our partners on that. And there's a great deal of information in the appendice on that. The integrated community mental health services is the other component of this. And this is quite complex, and there's been considerable, I think, challenges within our community services for many years in this system. I won't go through all the details, but I think one of the important things to note is that the work that we've done as a system to identify the challenges were identical to the challenges that were then outlined and detailed in the National Community Framework that very helpfully came out in late 2019. So this committee will understand that we were very, in a sense, relieved and supported by the fact that our plans dovetailed with the national direction of travel. Effectively, very briefly, it's all around fragmentation of services. We've got a number of specialist teams that don't necessarily connect particularly well with the rest of the system, and you end up with service users having to go through a number of different hoops to access different aspects of care through the system. So rather complex, rather confusing, and not particularly helpful for service users. So most of the plans that we've developed address that specific issue, and some of them address other issues about making sure that we've got a stronger psychological presence within our community mental health services, and to make sure that the whole system becomes less siloed, to use a cliche, and much more manageable for service users. The lack of strong psychological support within our existing community mental health teams has been noted by regulators and by partners and service users alike. So all of the challenges that we've got are addressed, and people can see the appendices in table 7, hopefully, to give some more detail on how we wish to do that. I think the only things I'd say in closing, Chair, are that there are some next steps really, which are sort of further validation of the clinical models and the agreement of the recruitment plans. I think puts us in an extremely strong position, bearing in mind this is all about investment and not about service cuts, which is a fantastic thing for somebody who's been in mental health services for nearly 40 years to be able to say, actually. So we now want to move towards the final stages of engagement, consultation, and then implementation of these plans. So our proposal is really to continue with our engagement approach, and we're moving towards finalising a business case in October and November of this year, and then that moves on to various governance plans with NHS England. So the recommendation for this committee really is to note the progress in finalising the plans in response to the challenge of this committee and to move at pace, and to make sure that as a system we identified and invested the appropriate national investment in urgent and emergency mental health care as a system across CCG and provider colleagues, and integrated community mental health services. Note some of the themes that emerged from all of the work with our engagement with patients and service users and carers and staff. Obviously, it's worthwhile noting the very positive feedback from the Clinical Senate, which is the independent review of whether the plans stand up to scrutiny clinically. And then hopefully comment on our plans to continue the process of engagement as we further develop the business case. And I'm obviously keen to stress that if this committee chair wishes us to come back at a later stage in the new year, when consultation and engagement has been through its processes, to give a further update, of course, we'd be very keen and open to do so. So I'll finish there, Chair. Hopefully that didn't take up too much of the agenda's time and you found it a reasonably helpful adumbration of the points.
Thanks very much, Gordon. I've currently got 6 people with their hands up. Thank you very much. I'll start with Melissa March.
Thank you, Chair, and thank you, Gordon. And I agree with much of what you're saying about how really encouraging it is to hear about the investments, and also the kind of the process of consultation seems, from what I can read, really really thorough, and so really welcome that, and thank you for that. I've got 2 questions. The first one is, as ever, about beds. I know there is a plan to, and rightly so, to get rid of dormitory accommodation at the Bradgate. I don't think that's included in this, is it? Because I'm concerned that when we remove dormitory accommodation, we end up with fewer beds, and that's something that concerns me, because in general, I think we're at a time where we are going to see, unfortunately, a rise in kind of mental health problems and mental health challenges.
I'm happy to take that, Chair. That's a very good question. We do have a plan to remove dormitories in line with national guidance, and for a whole host of other reasons that if you've ever been in a dormitory, you'll understand. And you're right, there is a challenge. I mean, we're in a strong place, as I said earlier, compared to most other systems in the country, in that we are managing our flow very, very effectively. That does give us the opportunity to remove dormitories in a phased and reasonable way. But it will be with its challenges, because there will be some changes in which some of the bed usage is managed, and that might lead to some small changes in bed stock. We're confident that as we do that, we'll be working with our flow team and our service users to make sure that that doesn't tip into any challenges related to out of area. Because you're right, we've worked really hard to make sure that service users get the inpatient care they need when they need it. We're not about to do anything to jeopardise that. So I think your point is well made. We're very cognizant of that, and we've got a plan that we think addresses that in a sequential and timed fashion to make sure that we're not hitting a wall in terms of a sudden drop-off of management. It's probably worth saying that we've had temporary changes to bed usage due to COVID, because we've had to manage certain wards slightly differently and support CAMHS colleagues. So we're actually using a considerable less number of beds at the moment on a temporary basis, but despite that, we've still managed our flow. I hope that helps.
That's really helpful, and particularly like the thing about February. I think that's really impressive. So thank you for that. I'd love to see some actual numbers at some point of like how many beds do we have currently at the Bradgate, given the dormitory accommodation, and what does the change to that mean? And my second question, Chair, is just about the intersection between, I see that Turning Point are mentioned in there, and obviously really welcome that, but there is this intersection, isn't there, kind of between addiction services and mental health, and when they overlap or people are in need of services connected to both, sometimes they aren't able to access either. And so what I'd really like is some confirmation that your no wrong front door policy applies to people who might be in that situation. So there might be people who are addicted to different substances and using those substances, and they're still able to access the mental health services that that are here, please.
Well, again, Chair, if I can address that, if it'd be helpful.
Yeah.
Turning our partnership, you're absolutely right. Again, I mean, that is a challenge across the country. We're addressing that in two ways. Firstly, our very strong partnership with Turning Point addiction services, drug and alcohol services, that we've got a very strong partnership with at UHL and that we're developing further. Because you're right, what we don't want is bounce around. So if I can give you a very clear example of something that happened yesterday, a service user that we weren't sure whether they did need mental health services or drug and alcohol services, and you're right, some need both. We absolutely work with that service user to make sure that we got them into Turning Point within 3 days. So I think that's the sort of partnership that we're developing. And I'll say one thing further, which is the broader Turning Point offer and partnership is going to be incredibly strong within our central access point. So there's an opportunity for us to work as a really strong, coherent system, I think, going forward, recognising the huge strengths that the voluntary sector brings and your points around drug and alcohol and mental health interface.
Thank you. Thanks, Chair.
Thanks very much, Melissa. Sarah Hill.
Thank you, Chair. I'm pleased to see this. As other committee members have been around will know, this has been a long-standing problem. As far as I'm concerned, it can't come soon enough, but I've got a nasty feeling it's going to be certainly well into next year before we can implement it because of the business case and the archaic processes that are around that. I've got a very specific area of concern that highlighted to me through somebody I know this weekend about new entrants. Single access point is great if you understand the system and know where to go. But as a new entrant to the system, it's like, boom, what do you do? And more specifically, their families who are in an incredibly vulnerable position. If you've been admitted as an inpatient to the Bradgate unit, you don't actually get a phone call from the Bradgate unit to the family saying, Fred's here, don't worry, he's not jumped under a train. And that bothers me intensely. Yes, I know data protection may say, oh, well, we can't ring them up because he said no, but isn't there a duty of care to the families who are sitting at home worried? And that bothers me. There's a lot of talk about co-production, but where are the families? Where's the information to them to say your loved one is now here? This is what we're going to do. And that, you know, you've done a great job so far. I'm not knocking any of this, but currently as it stands, there is an issue around that I didn't know about until it happened to a friend of mine this weekend. So it's about new entrants. How do they get to the central access point? Nobody at school probably knows that unless they happen to be involved in it or have got family who've been involved in it. So that's sort of where I'm coming from. Is there's a lot of good stuff here, and it's great to see the changes that are coming through. But I think there's a sort of side bit that may have been forgotten because everything is focused quite rightly on the service user, but they have loved ones who worry about them, and they're also vulnerable, but in a different way. So I'd like your thoughts around that, please.
Chair, if I may take the second point, and then I'll ask John just to briefly say around the communication of the phone number of the CAP. You're absolutely right. I couldn't agree more around the importance of carers. I mean, it is alluded to in the paper, but I'm happy to re-emphasise that working with carers is consistently one of the most important things that service users tell us in terms of the quality of their care. And we see that as an absolute commitment and something that we would do routinely because it's very difficult to develop a care plan without the carers involved. I can't comment on the individual case, but that certainly doesn't sound typical because routinely we would work with service users and their carers at the first opportunity, whether they're in the community or indeed on an inpatient. So if there was something
specific, I'm happy to take that offline because on World Mental Health Day, it doesn't look good. No,
I mean, if there's something specific on that case, then I'm really happy to discuss it with you and see if there were any particular challenges, whether they're related to the service user's wishes or whatever other factors. So, but the principle, I'm more than happy to pick up with you. John, if you want to very briefly just mention the how we've identified and continue want to publicise the phone numbers.
Yeah. Hi, panel. It's John Edwards. We've done some advertising. We've gone through social media, etc., to try and advertise one number. The work that Gordon trailed a bit earlier of bringing Turning Point together with what we've put in place in the central access point will create, in effect, one number. So if whether you, instead of having a separate crisis line and this number, it will be one number. And it's all designed to try to make it really simple that people know to ring one place. Equally, if people ring 111, under that same no wrong door concept, we've got protocols that means that directs it to the same number. So we're trying to channel people as simply as possible, because we recognise that how the system has been almost penalising people for not knowing where to go. So, but we absolutely got more to do to advertise it. I think we can all appreciate that and recognise that. So you'll see over the course of the next weeks and months getting a much greater profile of that number, so that people who aren't looking for it right now are aware of it, alongside people that are perhaps looking for it. And so that's work in progress, and we're trying to work with as many partners as possible to try and surface that number so that people know where to go.
Right, thanks very much, John. So what you're saying is, if people did phone 111, they would still be redirected to that number.
If their needs dictated that was the right most suitable place, yes, yeah. So the whole idea is to get the whole system just sorting itself out, and not mean that you patients or individuals need to navigate the system, which is right, for most people completely balmy or hard to understand.
Yeah. All right, thanks very much, John. Ted, you're next.
It was heartening to see with yourself, Gordon, that you said you'd got over 40 years experience in this in the field of managing mental health, and it's heartening to see someone so committed and experienced at the helm. So for your dedication, I thank you very much. So I've got several questions, if I may go through them, and with John as well. This report is very detailed. What could be added to it, though, and certainly I'm pleased, it would be greatly appreciated if you would come back, is that there are, if numbers were to be added to this, so for example, that there are a few numbers, but we could ask for some more, please. For example, on page 11.16, where it talks about the analysis of the outcomes of introducing the central access point, shows that 44% of patients who did call the number did not require secondary mental health. So obviously that means 56% did. But what are those numbers? What numbers are we talking about? It's good to have transparency over numbers, because of course the topic of the day at the moment is, with the pandemic, that mental health will increase. But especially as a committee, it would be good for us to know what the numbers are. What are the numbers now? Now, it's something that is, this leads on to the second point, that obviously it's quite easy local government speak, but this word signpost. So when people are encouraged to use the voluntary services, and this is mentioned on another page as well, and to other services, what do we mean by that? And also, when we are referring other people, encouraging them to integrate and to ask for help and engage with other services, what financial support are those voluntary services asked to? What financial help are these groups given? Because if 44% of people didn't require secondary mental health, or the 56% who did, but then also had other services out of the NHS, if those wider community-based and voluntary community sector partners don't have the resources, there is a strong likelihood that the people with the mental health problem will then return to the central access point, or even the urgent care hub saying, I tried that and it didn't work. So that's that. There are some figures there, and another figure, which is when we talk about the £500,000 for that you bidded for. Is this actually to pay the wages of the extra staff that it talks about? And is this a one-off £500,000 payment, or is this a £500,000 payment every year to cover these extra staff? And are these staff specifically just working with people who are inpatients, or is this for people for the outpatient services at Glenfield?
Thanks, Ted.
Thanks.
Take that up then, Gordon.
Thanks, Ted. Yeah, I mean, I've been around for a long time because it's a real privilege working with services and carers. Actually, and I'm very grateful for your detailed reading of the paper. Actually, these questions are incredibly helpful. I'll try and pick up a couple of them briefly, and then I'll ask some colleagues to come in and address some of the points. And hopefully, if we can't address it fully now, I'm happy to take it offline with you. First of all, I think your point around the evaluation and specifically around the numbers of people coming in. I don't have the up-to-date data cut, but they are very, very significant. I mean, as you like, we're talking about thousands of people coming through the CAP and the hub. But to be really accurate, I want to make sure that we accurately get you the most up-to-date figures. So I'll ask John to comment on that and pick those up with you. Your points around, I think, signposting are really, I couldn't agree more, actually. I think we tend to use the term signposting and it almost feels like you're just literally pointing people away from the door they've come to, which is enormously unhelpful. I think what we're really trying to talk about is there are lots of people who do phone and are asking, well, where are the services I should go to? And if it's not here, where are they? And I think that can be very helpful to be clear on that. But your point around making sure that the services and the community assets are actively resourced to be able to do that work is absolutely the heart of our thinking as a system. Because remember, this isn't LPT's plan, this is the system plan. And you'll see references to the voluntary sector through there. Probably we'd need to make that stronger as we go forward. We're clear at STP level that the need to grow and develop and support a really strong voluntary sector in the mental health field in this system is overwhelmingly powerful, as is the need to make sure that that links with existing services in neighbourhoods and communities, and that we begin to really build up that as a really strong network of support for all the reasons you've identified. A great deal of that work is actually within the neighbourhood work that we're developing, and I personally, after listening to your questions, would really welcome your involvement in that, because it sounds like you bring a great deal of lived experience and information and support too. So I think that'd be really helpful. So yeah, I mean, we absolutely want to make sure that we're not signposting people away. We're making sure that they're actively being supported into something. So I'll ask John to pick up the specific point around the money and anything else he wants to pick up in terms of the points I've made, if that's okay, Ted.
Thanks.
I'll try and be brief because I recognise your time, panel. But the effectively, I think your question about the demand for CAP had a wider connotation, which was getting an estimation of what the changes in demand are for mental health support in general, which central access point is a feature of, but people can present still to a range of places. And as a system, we're working up what will be our first comprehensive data set across all agencies, one hopes anyway. We're working on that, that would actually give us that kind of information, I think, going forward. It's not ready at this stage, but over the coming months, we're hopeful that will actually start to give us a full picture as to how people are using services at the moment and seeking help. So I think those sort of information and playing that back when it's in a fit state would be I think really helpful and interesting for councillors. In terms of the resources, the mental health investment standards that we're referring to are Yep, they're for additional resources. They're often for staffing resources, and they are recurrent. And they are also not just for professional mental health services. They're also for voluntary sector. And we've got a plan that looks to try and invest in a range of different places to try and do as you're describing, really, and build up the capacity. Really, in the thrust that you've probably read through the paper, which is really trying to drive as much support locally and have that versatile to meet people's needs. So hopefully that provides a bit more clarity on that.
Yeah, thanks very much, John. Is that okay, Ted?
So yeah, obviously, if we could have these numbers, I mean, it could be argued, obviously, couldn't it, that there must be some numbers immediately, because if we can quote this 44% and 41% reduction in patients, but certainly if we can have that for our next meeting, Chair.
Absolutely.
Thank you very much, Gordon, and I look forward to speaking to you offline.
Yeah, we can have that well before the next meeting. Because that would be helpful for you to understand what's going on.
Things are obviously moving. Next question, Gail Waller.
Thank you very much, Chairman. And Gordon, can I thank you for your introduction? It certainly helped me to understand this paper a lot better than when I just simply read it. But on to my two questions that I've got, please. The first is, how confident are you that it will not matter whichever part of the LLR region that you live in, that the service you will get if you have a mental health problem is going to be consistently good? In other words, there isn't a geographic bias. That's my first question. And my second is, in your table in paragraph 7, you talk about multidisciplinary teams and integrating health and social care. Are you talking about the social work services that are provided within health, or are you talking about the local authority social care teams? Because I can't speak for Leicestershire or Leicester clearly, but here in Rutland, we do employ staff who are mental health qualified within our social work services. So I just wanted clarity around that, please.
Thank you.
So,
something you pick up with, or perhaps
I'm happy to pick up the second point first, if that's okay, very briefly. Sure. So the information around integration is absolutely about what we want to try and do across social care. And I think you've outlined some of the challenges in terms of social work, mental health services. I think that's about us continuously working as partners to look at how we can join up better to make sure that we deliver a better service for our service users. And I think there are some challenges with that, but one of the first things we're looking at doing is making sure that some of the AMP services can be working more seamlessly within the CAP, for example, so that people don't get bounced around when they apply for that. And then I think ongoing conversations through an established mental health collaboration board, which has local authority social care colleagues on it, is something that obviously we'd want to continue to say, how can we make the services better for our service users, and where there are opportunities to better join up and integrate, let's do that. There may be opportunities to be more ambitious on that in the future. So I think that's a conversation that's ongoing. Your point really around making sure there's no geographical differences is absolutely core to what we're trying to do. We are confident, but I'm not complacent, is what I'd say on that one, because I think there are significant challenges. But as somebody who lives in Rutland and works and has spent a great deal of time in Leicester City, I'm aware of the geographical and demographic challenges and differences across the system, but we've just got to make sure that we do that in a way that makes sure that everybody gets what they need. We're confident but not complacent.
Thank you. Can I ask, Chairman, that when we revisit this in the spring, that some of the data includes geographic related data, and I'm not quite sure how that would be achieved. Clearly, numbers are straightforward. Yeah. But of course, you've got population differences and it's unmet need, I guess I'm looking at as much as met need. So if that could be included, please.
I think we'll be able to do
that. That's very sensible.
Thank you.
Thanks. And finally, Rosita.
Good morning, everybody. Well, as I'm the last one, most of my questions have been answered. However, can I just reiterate one of the points which were foremost in my mind, which was the first-time entrance, the simplification of the process, so that the service is well marketed, so that people out there actually know. But you have addressed that. My other point is very much, if you're making all of this investment, how will you eventually measure outcomes? Because I think that is very important to then look at your outcomes and pinch or amend where, you know, it hasn't worked as well as you were hoped. So that is question one. So how do you measure outcomes, and how do you deal with that, with those changes? And my last question is very much timelines, because, you know, when will this all come into fruition, and when can we actually see tangible outcomes? Oh, and I've got one more point. The whole process seems to be very, very confusing to people like me. So how can anybody else understand? Could we possibly see maybe a flow chart with the next report, how it all fits together and how the whole cycle is completed? Thank you for that, and very, very good report and good work.
Thank you for those comments. I think your suggestion of a flowchart is extremely helpful, and we'll address that. Anything that aids the understanding of the complexities. Can I just ask John to pick up the other two bits very briefly?
Oh dear. Could you just caught there? So
do you want me to pick up the outcome question?
Yeah, it was specifically around outcomes. I'm happy to take it.
Okay. Thank you.
Paula, do you want to come on the outcomes component?
I'm happy to do that. Good morning, everybody. My name is Paula Vaughan. I am the head of commissioning now for the 3 CCGs across Leicestershire and Rutland for all disabilities, autism and dementia. Thank you very much, Gordon, John and Chair. Just in terms of your question, Councillor Page, on the outcomes, I think it's really important, building on what you've already heard this morning, that we try and do something that isn't just system-based, but it's really locally based as well. We've got a really exciting opportunity with the newly formed primary care networks that have been in place now about a year. They're starting to develop and become quite mature. And those groups of individuals wrapped around those primary care services are really starting to get to grips with their communities, what their communities need. And it's really important that those outcomes, therefore, aren't just big numbers that look across the whole system, that they're actually based around each of those individual communities. I think that conversation fits in really nicely with the idea of really trying to get to grips with those health inequalities, those understanding of those different communities and neighbourhoods and what they need from a mental health and wellbeing perspective. And that, again, fits around those conversations you've already had this morning around that investment into the voluntary sector, and into building up and making more resilient those community groups that add that mental health and wellbeing offer, maybe at the more of the lower end and lower end of mental health services. So certainly from an outcome perspective, I'd really like to see that we don't just start communicating things at a system level, but that we do that based around each of the places and neighbourhoods as well. That will take time, as in, you know, a couple of months, which is looking at the end of this financial year to try and do that properly. But I want to do that with our partners in Gordon and John, but also all those clinical directors of those primary care networks, so they start to, we're in dialogue with patients and experienced service users, understanding what those outcomes should be for each neighbourhood, because I think they will be different, and I think that's important that we recognise that. Is there anything you wanted to add to that, John?
No, I think to complement that, the data stuff that I was referring to earlier is a key part of this, so that we're actually combining up all of our information from all of the systems, because so I think with all of those combinations, we'll actually get a really strong impression of how successful we are. And not one of these initiatives in isolation is going to make the difference. And I think we're appreciating that. So it is about how we can look at it as a combination. I think that what we will be doing is probably bringing back in iterations that, because it's going to take time to develop into a kind of clear picture, I think. So it'll be good to start to bring more and more levels of detail about the outcomes as we go forward over the next months and years.
Okay, thanks.
Can I come back on that, please? But the outcomes, you have two sets of outcomes, in my opinion, not only on existing patients, which is easier to measure, but it is the new entries. And for instance, it's extremely difficult at the moment for my residents to access their GP services. So if they cannot access a GP service, how can a person who possibly thinks, especially at this time with COVID, that they have got some potential mental issues, how do they get into that system? How do they get seen? So we are back to the point that of the first time entries, how, you know, the outcomes there is how do we pick up these people who need the care? This is my concern rather than the ones which in the system. Can you come back on that, please? Thank you.
So I think a range of ways, because what we're talking about, I think part of what you're talking about is the people that don't make it into services as well, and how we actually understand that unmet need. There isn't a straightforward way of measuring that, unfortunately. So we've done some survey work during the COVID period, but we didn't get a massive amount of return. We're trying to work with voluntary sector in particular, who do have greater reach and connection with different communities. And I think that through that work in particular, I think we're going to get a more rounded impression as to, you know, how successful is the way that we're configuring ourselves at the moment and advertising ourselves and making this accessible in every way. Are we then attracting that need? Gordon, I think, referenced on the chat the work that we're doing to try and analyse the demographics of people that are accessing and using services at the moment, and that is pretty clear that there are aspects of our services at the moment that don't have the representation of the different communities that you would expect from a sort of population perspective. So that would give us a pretty good idea that we're not currently offering our services in the right way, or indeed advertising it, or a bit of both, really.
Chair, I would take the challenge that says we need to do some more work on being clear around the importance of demonstrating outcomes, both clinical reported outcomes and patient reported outcomes. I think it's a very helpful challenge, and we'll make sure that we do some more work on that to make sure that's clearer.
Yeah, thank
you very much.
There was one more, but it's gone. So I think
that was me.
That's all the questions I've got. Thank you very much, Gordon, Paula, and John. You've answered the questions. I think hopefully you've learned some of the areas that we'd like to see further updates on. And if we can have an update, obviously, from you in the spring or next year, that would be very helpful. Thank you very much. Oh, Harsha, you've come back.
Sorry.
Health Watch Leicester. Yep, go on then, Harsha.
My question or comment was just, I did put something in the chat, but I just wanted to say around ethnic minority communities and how, you know, you're addressing the issues around mental health. They don't recognise it in the same way. And I know you've put something in the chat, but I would like to see something specific around what you're doing and how that is being communicated.
Yeah, I think
I'm happy to talk about that directly with you, Harsha. We're just setting off a program now that I would very much hope that you'd be kind of involved with, actually, around doing some data-based work on equality of outcomes and access for BAME service users. It's a piece of work I've done in other systems, and I'm very keen to do it here. So we've actually set off the data work on that now. So I can talk to you outside of the meeting about that.
Okay, thank you.
Yeah, and I see Deborah's come back on now. Is this the similar area you want to look at, Deborah? Because we really need to move on.
I realise you need to move on. However, I'm really concerned that we haven't addressed the access routes for African heritage communities.
Yeah.
We know that African heritage communities' access to mental health services is predicated on crisis and through the legal routes. And I'm not sure that the report you've presented has given me the satisfaction that we're going to be looking at that squarely. I understand you're saying BAME, as in Black and Minority Ethnic, but I think there needs to be a specific piece of work for African heritage communities. Sorry, Dr. Felton.
No, fine.
Just briefly, Chair, if it's helpful, I'm happy to have that conversation outside. That will include some very specific work about African heritage, Councillor Sangster, and that's some of the work that I've done in other systems, particularly young Afro-Caribbean males who have higher disproportionate admissions to PQs, and some of that work, which I've got some experience of. So that will be part of it. And I'll be really happy to get your thoughts on how we can make sure that that lands properly.
There's some interesting work done by Fabian Palmer.
Absolutely.
You've seen that?
Absolutely, yeah.
Okay, and that's the kind of, those are the kind of issues I think we need to be able to address. If you could send me your contact details, we can speak about it further outside of the meeting.
I'll be happy to.
All right, thank you.
Okay, thank you very much. Thanks very much, Sir Said, and we'll look forward to further work, obviously being reported in due course. So move on to item 7. Need to move on now. Liaison Mental Health Service. Looks like it's you, Gordon, and Paula again. If you could, it's only a short paper, but
yeah, I think Paula's going to talk to this one, Chair.
Just
it is a relatively short.
Just for a little bit teamwork. I've just introduced myself. Hello, everybody. As you say, it's a shorter paper, Chair, thank you, but I've got a quick summary for you, which I hope will be helpful. I think this really builds on the work you've already talked about and discussed and seen from Gordon and other colleagues this morning. This is about a proposal to integrate the different mental health services that we currently offer to UHL's patients. And this is about really understanding the very real way in which physical and mental health are integrated and are part of each other. They're really, really interlinked. We know about the huge impact one can have on the other. And we also need to think about the fact that every person experiences that really, really differently. And I firmly believe, and I know colleagues and in terms of Gordon and John really also believe that we need to continue to invest in and develop that service so that it's more responsive, it's more accessible, and it works for every patient. I think it's really important to highlight to this committee, but I'm sure most of you are already aware of the fact that the impact of complex diagnoses can have on mental health, and not just of the patient, but also the people around that patient as well, their families, their carers, their children, their parents. Those diagnoses we're talking about, so we're talking about cancer, diabetes, heart failure, genetic conditions, COPD, all those really big diagnoses, and often patients don't just have one to contend with at the time as well. We probably should put COVID into that mix now as well, because we know we're hearing more and more about long-term COVID diagnoses, and that's going to be difficult for lots of people. And we also know that the impact of mental health isn't predictable. So it might be at the point of diagnosis you find it difficult. It might be much further down the line. And this is about understanding that everybody experiences that really, really differently. So this is about, as I said, trying to build on what we've already got. In the paper, it does summarise for you in the table on the first page, I believe, the different liaison services, which is what we call mental health services in a physical healthcare setting, what we've already got in place. And as you can see, they all operate slightly differently. They operate differently in terms of access time. They operate differently in terms of opening times, when you can find them, when they're working, and all those other things. And as we all know, as you have different times and different opening times and different methods and methodologies of accessing them, that makes things really complicated for people. And the last thing anybody needs when they're experiencing mental health issues is something complicated to try and navigate. So what the proposal is really looking at is, firstly, we've got some really good news. The system we've secured an extra £500,000, which I think might be the £500,000 that Councillor Parton was referring to earlier. This is transformational funding, so it's recurrent funding that goes into the system to supplement and enhance the liaison services we've already got. What we're really looking at is trying to create what we call a call 24/7 service, where we bring together all elements of that clinical liaison mental health services across UHL, bring them together, supplement them with the new posts that were explained in the paper, the 2 psychiatrists, etc., to create a service that can respond to urgent mental health need for any patient who is who is either in UHL or having care with UHL on their site, within an hour of that need being expressed to a member of the team. That's what we're talking about, a really fast-paced service that can go out and work in that hub and spoke model across all sites across UHL to offer that support to people. Now, we are also aware of the fact that obviously when patients then go home, that these, as I've just expressed, that patients are having long-term types of care. It might be outpatient care, it might be chemotherapy, it might be radiotherapy, all those different times. Patients then experience mental health exacerbations at various points. And what we want to do is then invest additionally into the IAP service, which is our therapy service, which has got a very fast time in terms of assessment, and then also therapy, step one therapy that follows that for these patients as well, so that you've got that real hybrid model of accessibility to psychiatry, therapy and treatment services for patients who are experiencing mental health issues because of complex physical needs. And it's not just about one type of diagnosis, it's about all patients across UHL who are suffering with complex physical needs that then exacerbate their mental health condition. Now, this is obviously just a proposal at this point. The paper outlines for you how we're expecting to try and do some meaningful patient engagement, but also for me this is really important that we keep this a really open dialogue. We're aware of the fact that obviously some patients are already in the situation and have been accessing various types of mental health and liaison services like therapy. This is not about trying to break that. This is trying to bring that together to make the service more robust, but it absolutely therefore has to be done in partnership with patients, and it has to be about a dialogue. For me, therefore, not only does that then help us shape the service we want to put in place with the money we've got this time, but this is about making that dialogue a more permanent arrangement, because this service will continue to evolve over time. As obviously we're going to talk about new services moving around the city, it has to work with that as well. So this is about a dynamic arrangement and building that right from the beginning. I think that's all I've got to say at this point, unless any colleagues want to come in and support that narrative.
Thanks very much, Paula. Just to say to people, if you've had your hand up before to ask a question and you now don't need to ask a question, can you put your hands down? And it looks like I've got Sarah Hill though first.
Thank you, Chair. I'm going to play something you've heard before from me. This is great in UHL. What happens if you're a Leicestershire resident who happens to rock up at an A&E out of a county, or you're an inpatient or an outpatient out of a county? Because an awful lot of people from my area, Market Harborough, Rositas and Lutterworth, people from Rutland, people from Hinkley and Bosworth, don't come into UHL. And they may need mental health support. And I've got visions of weird handovers and non-existent handovers. And so I know this is focused on UHL, and it's a great idea, it's a great service, but I'm worried about Leicestershire residents who don't ever turn up there and are then stuck in other people's services, and then they're sent home. You see where I'm coming from? There's massive handoffs, and it's always been an issue around the county, because most of the county towns appear to be near the edge. Thank you, Chair.
Yeah.
I'm happy to answer that if you're happy, Gordon. I would see that absolutely. I completely agree. It's a perfectly valid challenge, and I completely agree. Two things. I think in terms of the actual care in the hospitals themselves, our model is built on the best practice model, and I know other surrounding areas are trying to do the same thing. We've got very strong partnership links with Northamptonshire, who are obviously heavily influencing the model that's going on in Kettering and Northampton. So from that perspective, and I know that's not all the borders around LLR, but it does help us start building some of those bridges and getting them right. If we get them right, trying to then duplicate that offer around the border of LLR does, I think, help us do that. In terms of the IAPT and the therapy offer, that is obviously for all LLR patients, wherever they go to in terms of their inpatient care, they can be referred straight into the LLR IAPT therapy service. I do completely take on the challenge the fact, though, that there could be issues with a handover. There shouldn't be in terms of referring from inpatient to IAPT, because it's a self-referral portal. But I will happily go and take that challenge and think about that and how we make that more robust and slick for patients. Thank you. That's really helpful.
Thanks very much, Paula. That's a good one. Gail Waller.
Thank you very much, Chairman, and thank you, Paula. I would support Dr. Hill's comments as a councillor in Rutland, and obviously residents here go off to Peterborough and Kettering, etc. But my question is also actually related to the IAPT service. We are geographically not perhaps particularly large LLR, but an awkward shape, and our towns are not necessarily where our people live in our villages. And you talk about community-based talking therapies, Paula. What do you mean by community? Where do you envisage these happening, or are they going to be simply using modern technology online. And I'm not against that. I just want to understand.
Absolutely. So I've got a vision of kind of a two-level based service. There is absolutely something around our Leicestershire and Rutland IAP service offering more online services, and they have had to move that way anyway because of COVID. That doesn't work for everybody, so getting the balance right is incredibly important. In addition to that, I come back to the primary care networks because they are, for example, in Rutland, obviously Rutland Health is a very mature and well-developed primary care network that's doing really well in terms of integrating its services around primary care and health and social care as a whole. Those primary care networks from April get separate funding for mental health practitioners and wellbeing practitioners. So they have the opportunity to look at the needs of their population. So we take Rutland for an example, look at their fact that obviously they've got as you said, the geography is not colossal, but obviously a significant number of patients live out of Oakham and live out in smaller villages and might find it harder to access a service in Oakham. But that doesn't mean that they won't be able to, because I know Rutland Health have got some thoughts around how can they invest that money into the right kind of therapy and practitioners to supplement what is the IAP service that we commission at a system-based level. So the two absolutely have to work hand in hand. So we've got an opportunity to commission and deliver a talking therapy service, which is delivered both face-to-face in more prominent towns, I guess, and then digital offers for those for who it works. And then to supplement that, there will be something that is delivered by each primary care network that should be absolutely aligned to the needs of those local people, those local communities. So in Rutland it might be, and we'd have to talk to Rutland Healthcare, and perhaps we might go and have a meeting with Hilary Fox about this afterwards, about some of her ambitions for Rutland and how she sees that. But it's that opportunity to really understand that local community and what they need. And that's where I think we start having those conversations we talked about earlier about health inequalities, different ethnic groups, how they talk about mental health, and actually where you might target some of that work. For some of those primary care networks, it might not be therapists. It might actually be a completely different group of people who can go and have a different conversation and spark that interest in mental health and well-being that is needed in one area that isn't necessarily needed in another. Does that make sense?
It does. It makes perfect sense. Thank you very much, Paula.
Thanks very much. And now another question about Rutland, I assume. Sam Harvey.
Thank you, Chair. My question is for the kind of around the whole of LLR. Just regarding your comments regarding long COVID and looking at services moving forward to those suffering from long COVID, I was wondering whether you are going to include patients that currently have a diagnosis of ME or chronic fatigue, because currently there is no service in LLR for those patients.
Absolutely. So a liaison mental health service, and I'm looking at Gordon and John in case I'm saying anything, but this is entirely how I see it and how I believe in it, is a service for any UHL patient who is suffering with a complex physical health diagnosis. And that for me, we absolutely include chronic fatigue and ME. So if they need access to urgent medical health and they happen to be at UHL, that's what that service is for. If not, it would be absolutely incorporated into the talking therapy service. It's entirely appropriate for me and entirely the right thing to do. That's my personal commitment to it. Absolutely. It should be for every patient that's got a complex diagnosis, because the two go hand in hand, and it's so very important.
Thank you very much, Paula. Is that all right, Sam? Yeah. Amanda.
Thank you, Chair. Just two really small points from me, really. Following on from the previous paper about outcomes, it'd be really useful to understand what you're expecting to see in terms of throughput because of these changes put forward. And secondly, one of the things that strikes me in the report, but it might not be fair because it can't, it can't cover everything in the report, is on point 11, for many people and their families living with cancer. I think that the concern I would have is quite often families don't understand all the medication that's been given to their loved ones. So actually that can be quite challenging as their disease progresses, and understanding all of those things is important. However, it's about end of life support for families and how are they supported through that post somebody maybe dying of cancer. And having been through that myself, it feels like, oh, you know, the patient's passed away now. These services aren't open to you anymore. And I think it'd be really useful to understand how those individuals who are grieving are able to be not pulled out of the service, but given that support post dealing with something like that.
Thank you ever so much. Can I take the second part of your question first, and then perhaps I might hand over to John in terms of understanding some of the ideas around throughput and activity through the newly modelled service. That'd be quite helpful. Just going back to the second part of your question, I happen to have been part of the end of life team just before I came into post in this role, and I'm aware of how much work that's gone on in terms of supporting families and patients through that journey. But it did occur to me actually that post a patient passing away, that we haven't yet at all, for me, linked up the bereavement services, the services of those hospices and the end of life team and the mental health team and the therapy services. I think you're entirely right. I think those things are absolutely not yet integrated. I don't think it should be anything that's difficult. I think it's some sensible conversations that can happen quite quickly in order to plug those things in together, just to make sure that families don't drop through that gap post that sad family event. Thank you for bringing it up. I completely agree. I'm happy to take that on. If you'd like to talk to me afterwards as well, just to make sure that I do follow through that and make sure it happens, I'd be more than happy to do that. Thank you.
And John, were you going to pick up the first
yes,
point?
John, would you mind just on the throughput and the predicted activity when we bring the services together? That'd be really helpful. Thank you.
Yeah, so I don't have the figures to hand, if you forgive me for that, but in terms of the activity, so in terms of the activity to A&E, etc., we're seeing a few different interesting things. The bringing together the service doesn't necessarily alter the activity, if you see what I mean, because it's a responsive service. The nature of what some of the other initiatives that we put into the system, particularly the mental health urgent care hub, is having a notable impact upon reducing the number of people attending the emergency department that need that support. So hence why you can see it all coming together as a whole system, if you see what I mean. So which allows us really to make sure that the capacity we're putting on there means that we can be truly responsive. And obviously there is that ambitious 1 hour target associated with people that present, and compliance with that is increasing. So I think the combination means that we're allowed to, you know, we'll actually deliver a very responsive and well-rounded service. So I don't know if that directly answers your question. I think if we want more specific figures, a bit like the previous item where there's some interest in getting some of the data, perhaps we can try and look at how we wrap those data together, so you get a kind of more complete picture of how people are using the system at the moment.
Yeah, that's really, thank you, Paula, for that. That was really helpful, because my expectation was actually is that the pressure points will be in different parts of the system, and actually dealing with 80% of the cases earlier on would obviously save not just lots of resources, but lots of unnecessary treatment, maybe, because you're able to manage it earlier in the process. So no, that's really helpful, both. Thank you.
Thanks very much. There's a hand up from a Sarah Prima. Maybe not.
Sorry, that was a mistake. Sorry.
Okay. Finally, then, Janet Underwood.
Thank you, Chair. It's a question for Paula, really, and it stems from my own experience of working in UHL in a specialised service which is commissioned by NHS England and is in renal failure and transplant, etc. And we were taking in patients from as far away as sort of Skegness, etc., from a wide area. We were also dealing with a lot of patients with complex diagnoses and psychological problems, and even to the event that sometimes the illness itself was causing psychological problems, but psychological problems had also caused patients to, say, overdose on paracetamol, which caused organ failure, etc. And what I'm wondering is, yes, I think the service is absolutely brilliant if somebody can call on it and be and a nurse can call on it for a patient and help received within an hour. Is this 24/7? And also, what happens to these patients from outside who are resident outside LLR when they're discharged from UHL?
Thank you so much, Janet. Firstly, the short answer is yes, 24/7. Call 24, thankfully, is what it says on the tin. So hopefully that's useful, especially to UHL staff as well, so they know what they're getting, can expect for patients. It's, again, a really, really valid point. We've given some consideration to the early comments about outside in, but possibly not inside out in terms of that patient movement back out of LLR. It's a very, very interesting one, and I think you're right, there are specific pockets of specialist services in UHL where that would apply more than it would for others. With your permission, I will go and give that some thought. I'll go and talk to some UHL colleagues, and I'm happy also to take the renal transplant or perhaps ECMO, one of those sort of specialist services where there's more patient movement across boundaries, as an example to go and work through to work out what that might mean and what that could look like. It's not an easy one to answer because, as you know, as soon as you start trying to hand over complex care, especially psychological therapy complex care across systems, it gets more difficult, but it's absolutely something we need to think about. Thank you, Janet.
Thanks very much, Paula. Okay, I'd like to move on then to item 8, which I think is Peter Davis. I've seen his face somewhere in this system. Transforming care, learning disabilities and autism. And over to you, Peter.
Thank you. Thank you, Chair. Hope everyone can hear me and see me. And it's a double act today because my colleague from LPT, David Williams, is also on the line.
Yeah.
And so we've agreed that I'll do the first 5 slides, and then David will do the last set of slides. This relates to the Transforming Care programme. And don't say I've lost a pack. No, I haven't. I thought I had a glitch there. So this is a call to arms, basically. It's an approach, strong leadership approach, myself and David, adult social care across LLR, and also working with health colleagues and David Williams. We're both the joint senior responsible officers for the Transforming Care programme in Leicestershire. And I'm sure that committee members are aware of the background to this. This had its genesis back in 2011, the Winterbourne View scandal. Terrible examples of abuse to residents in a residential home in South Gloucestershire, a panorama investigation and criminal convictions, and then the former Prime Minister David Cameron making a commitment to the programme, which started in 2005. And so today's presentation will focus on where we are as a system, and we'll focus on outcomes, inequality, and the actions and the steps that we're taking. So the first slide is the story so far, October 2020, and the feedback that we've got from NHS England and NHS Improvement is that, as the quote, a very strident quote, the system and LLR is failing people with learning disabilities and or autism by keeping them in a more restrictive environment than the assessment of their condition gives rise to. And that was a statement made in April 2020 when we had NHSI coming to review our Transforming Care programme, both regionally in comparison to other regional areas and nationally. So clearly not a good story. The approach, following on to the next slide, this slide here, slide 3, talks about the detail of transforming care. And it's made up of various components. These are patients and service users who will have the most complex learning disability, the most complex autism, and their life stories. When you look at their life stories, a lot of loss, a lot of sadness, a lot of missed opportunity. So we're acutely aware of the need to improve the outcomes for this group. And the Transforming Care programme looks at various elements. So it talks about a trajectory of performance, and that trajectory of performance looks at the numbers, the number of patients that we have, both over 16, so children, young people, 16 to 18, or even younger in some rare instances that we place in inpatient settings, and also adult performance and the route that these patients, service users can access these beds, both within our local economy and externally. So there's forensic patients. These are highly complex, often with a record of criminal activity, conviction. So there's a whole number of patients, and there's a trajectory for each system, which David will talk about later. And suffice to say that our performance against that trajectory has been poor, and we haven't met the trajectory. The other element refers there, the bullet point, annual health checks for service users. And this is activating our primary care, GP practices, and awareness collectively within community primary care services to be alert and vigilant to the monitoring the needs and the annual health checks of this cohort of patients. And then we know from an inequalities perspective, premature death within adults, particularly with learning disabilities, mortality rates are not good, not the way they should be, and there is a leader review, so learning from the deaths, early deaths of adults with learning disabilities, and there's a prerequisite that systems have in place necessary vigilant systems to audit and learn from all of these deaths. So the approach that we're taking is we've called it a call to action, and myself and David and the teams from LLR, Adult Social Care, Children's and Health colleagues have set out a process called FIT. That's a mnemonic that we are using, a focus on the patient. That's the F bit of it. The I is the focus on integrated teams, both actual and virtual. Obviously, we've had the difficult challenge, huge challenge of COVID, but we work and aspire to and do work in a more integrated way now, with weekly meetings and ways of transacting which are much closer together. And the T is the focus on the outcomes element, the hard-edged focus on trajectory, our trajectory performance. And David will focus on some of the challenges that we've faced, but also I think some of the more recent successes in terms of the improvements that have been made. Then moving on to the next slide, the vision in this call to action. The LLR TCP vision, all people with a learning disability and autism will have a fundamental right to live good, fulfilling lives within their communities with access to the right support from the right people at the right time. And it's important that we spell that out and that I actually say this, and David says this, and colleagues across health and health and social care say this, because it's obviously a fundamental human right and clearly a commitment that we make today. And then if we move on to the fifth slide, this is kind of the national priorities. As I've alluded to, the programme initiated by Prime Minister Cameron and the TC programme, it's headed up by Ray James at the DH. Ray James is a former director, I think, of Essex County Council Adult Social Care. So again, we have a strong partnership flavour. We'll only be successful if we look at improving our practice, getting clinical oversight and clinical buy-in and support, obviously putting in good quality social care assessment, and again, it's that integrated partnership approach. And there are a number of key dimensions to good, effective transforming care, and they will focus on the prevention of admissions. And that's about diversion, it's about good quality assessment, it's about how practitioners from health and social care work together. The next element is that inpatient experience and how we make that, support that, make that as outcome focused and as unnecessarily long as possible. So there's a sense of movement and progression. And then the third component is discharge. And the whole element of discharge is based on effective movement from a setting of a patient to a community setting, not within a long stay hospital, but within the community, working with providers, effective discharge planning, and at its best, at the Transforming Care Board, we've had presentations from service users who have been in long stay settings, who have come out and worked within and lived within community settings, but they'll have a team around them. They'll have support from health. They'll have support from adult social care, and it's quite humbling to see what that experience has been like at its best. But we do have a lot to do to improve that discharge planning, working with providers and the market, and actually building a set of very adapted, very good quality buildings. So those are the first slides that kind of set the setting for this call to action, and I'll pass on to my colleague David.
Thank you, Peter, and happy to go on to the next slide. I've just got three that I'll just take you through. So just wanted to get you to understand a level of challenge and where we are going. The black line that you can see on the slide in front of you is the trajectory. That's the number of service users that NHS England would expect that we would have in hospital across LLR, and the yellow bars are the actual numbers that we do have in hospital. So we're above where we need to be, and we've been above where we need to be since April 2019, and actually you can go back further on the data series and see that we've been above that for a period longer. However, the last 3 months are starting to show us that we are achieving and delivering and getting people out, and we're seeing the green shoots of all our recovery plans and ways of working. It's making a substantial difference. I will just give you one case study as an example to understand. It's really important that we support people to get back out into our community, and nothing can be better example than an individual that we discharged into the LLR community last week who'd been in hospital for 12 years. So it's 12 years of working things through. This is a real opportunity to champion and improve outcomes for what's a small number of individuals, but really important individuals that we want to support in LLR. So that's a really strong example of some of the work we need to do to get people out of hospital and supported to live well in the community. If we can go on to the next slide, please, that picks up the information we've got around annual health checks. And annual health checks for people with a learning disability are really important. It's that chance to pick up and identify people, any health problems or other things that can come from having differences in being able to communicate, and therefore not being able to respond and pick up on their own personal well-being and signs very quickly. So in 1920, our performance was that as a system, we provided annual health checks through primary care to 53% of the people with learning disability or autism who are eligible for them. COVID's had a real impact on how we can do that, because you do need to see patients in order to do their annual health check. So our current performance across the different CCGs and the different general practice, when we produced the slide, was 10 to 17%. We're now actually at 19% across all of LLR. And we need to drive that forward to 67% before the end of this financial year. So we're working with GPs, the systems. Paula, who you met at the last presentation, is very heavily involved in changing the way that we do this. And if we go on to the next slide, I'll just give you an example then of why this is really important. And it comes into the learning disabilities mortality review. So anybody who dies with a learning disability, they have what we call a leader review. So we look at the reasons why and where things are. The important thing, I think, for you to hold in your mind about why we need to change and how we need to do this differently is that the median age of death for people with a learning disability in LLR is 59 years old. If you live in LLR, you're likely to live 23 or 27 years older, depending on whether you're a man or a woman, than you will do just by having a learning disability. And in the nicest way possible, to make this as concrete and as clear as I possibly can do, it probably means that if the audience that was with us today on this Teams meeting had a learning disability, many of the audience, many of us wouldn't be here now. And that's the difference in the life expectancy that we want to look at and work through. So we've also got some challenges around making sure that we've got proper and appropriate access from all population groups to supporting that and working it through. And if we just go on to the final slide then, I just wanted to share with you just the last little bit, which is about our call to action. So Peter's talked about how we make everything fit, how we focus on the service user, how we look at everything we do as an integrated team, and how we target everything on delivery. Peter and I are taking it forward. You can see that we've got some green shoots. You've got absolute commitment from professionals across health and social care to deliver this, tackle it. But my call to action and our ask from you today is, please do consider everything you can do to support and champion the needs of care for people with a service users, for people with a learning disability or autism. With good, strong community services, we're going to get the difference. We're going to make the difference that our population deserve. So your support to help us drive that forward is really helpful and really welcome. And that's the conclusion of our presentation today.
Thank you very much, David, and thank you, Peter, for your earlier bit. I've got a couple of questions. Ted Parton.
It talks Peter was talking about the lower life expectancy. And early deaths. Would we be able to provide some figures, some evidence-based figures for that, please?
Yeah, I mean, we can share. So the leader report, which is an annual review of all of the deaths of people with a learning disability in LLR, is a public document. So we can give you a web link to that to share the numbers and all of the detail and the reasons why.
Yeah, that'd be very useful. Thanks, David. And Gail.
Thank you, Chairman. I've got two questions. If I can find the right page. Yes, here we are. The first one is, how do the annual health checks vary across LLR, or is it similar levels in each of the three parts of LLR? It's my first question. And my second question is, different local authorities clearly work in very different ways. So here in Rutland, we have transition workers that start working with young people at least at the age of 14, if not younger, and their families, to help them transition through to adult services. And we find this has been very positive in terms of outcomes for these young people when they become adult and are in the adult context. And I wonder how much, as three local authority areas, we are learning from each other's practice in order to improve outcomes for this vulnerable group. Thank you.
Do you want to do the first, David?
Yeah.
You did the first, I did the second.
Yep, lovely. So in terms of annual health checks, performance does vary across the three CCG areas, and we're monitoring that all the way through. But the expectation and everything we're following through on is the national indicator is 67% of all individuals who are entitled to a health check with a learning disability or autism receive it. And we're expecting every single part of LLR to achieve that. So there's no differentiation. We're not trying to make it high in one and low in another. We want everybody to be able to support everybody in their communities.
Thank you. That wasn't the purpose of my question, though. I appreciate that. And I would hope that you would want to exceed the national average as well over time. My question was, as councillors from the three areas, we would like to know how our particular area is doing, because there are questions we can ask locally of our GPs, for example, that we can't ask if we don't have the information.
So the slide 7 said that the performance varied between 10 and 17%. That's the difference between some of the three CCGs. Currently, the LLR summed together performance, because that slide's slightly out of date because we're tracking on a weekly basis, is now 19% against a target of 67%. So every single area can improve.
Sorry, Chairman, is that because of COVID, though?
No. It's not, it doesn't make it, COVID hasn't made a huge difference. When we compare the actual numbers, there is not a huge difference between the actual numbers that were done in the first 6 months of last financial year versus the first 6 months done in this financial year. So there is plenty of opportunity to go and achieve, and COVID, we're absolutely committed to. COVID is not a reason for us to fail.
Okay, thank you. And my second question.
The second question, which was talking about, or the question about how different local authorities work together, transitions and the pathway to adulthood. Certainly in the county, we've got an approach to that transitions preparation for adulthood. It was launched last year. It's part of a whole life disability approach. So you've got transitions, you've got the SEND agenda strategically, and obviously there'll be links to the autism board that I chair, LLR wide, and also to learning disability board, and then to this smaller cohort of patients and service users. But nevertheless, again, it's about that partnership working. So specifically for TCP, Kim Skorsky, John Morley have been parts of the programme, the overarching executive board, and they sit on that. Tracy Rees from the city sits on that. So the senior managers certainly work together. The level of numbers from Rutland around transforming care are not as great as city or as county, but the model that we're trying to develop here is an integrated approach, and Rutland will be part of that. And so we are learning from how we work together, in particular around case management. So within health, within the CCG, there'll be case managers, case reviewers, and equally, adult social care and children's will have allocated social workers. So there's more work to do, but we are certainly working in a more integrated way and learning the best practice. And the best practice is about making it seamless, timeliness in terms of the discharging, and first and foremost, to get that trajectory down, because we know it's not the best set of outcomes for those patients, to avoid admission. So you have to be working with the providers, and there'll be best practice elements in Rutland that we learn from, indeed in the city and indeed in county. So there is an emerging model around how we're doing that locally. It's based on partnership model between health and social care, and clearly there will be examples of good practice from Rutland City and the county. The very demanding work from a social care perspective, because it's highly specialised, and you also have to be a micro commissioner. So you have to know the market and anticipate what's the best building, best setting with all the adaptations, the best team for your particular service user, client, and or patient. But I would say we are working collaboratively together and learning. We're doing a lot of learning particularly on TCP.
Thank you. I'm very pleased to hear that. I don't underestimate the complexity of the work. It's an area I did work in from a local government perspective. And simply because Rutland has few clients and is small, I don't think should underestimate the work or the approach that we have here, because I have used the very same approach in a far larger authority before I retired. Thank you.
Absolutely. I defer to your experience, and I didn't want to cause any offence unnecessarily.
None taken.
Okay.
I've got Melissa, but Janet Underwood, were you asking a question? You've got your hand up still.
Yes, I was. Thank you, Chair. It's actually not my question. Our Vice Chair of Health Watch Rutland is a carer for her 28-year-old son who has Down syndrome and autism, and she is his carer. She's also very active in Carers UK, and she's actually crafted this for me to say. She also said she's an expert by experience. She wants me to say that parent carers locally and nationally are at breaking point due to lack of support during the COVID pandemic. Many services have stopped. Carers are receiving little or no support and are having to actually fight to get help. The LLR projected trajectory demonstrates a projected steady decline in the number of inpatients with learning disabilities, and yet the number is only one less than 18 months ago. Why? Why aren't health checks happening? Why, as stated in the Lady Review, are only 17% of referrals from the Black and minority ethnic population? And in whose best interest, as on the slide, are the decisions being made on behalf of the local authorities, the hospital trusts, carers, or service users themselves? Thank you.
Shall we just start, Peter?
Yes, please. Yeah.
So I think if we start with just the last point, absolutely, the decisions that are being made are about in the service user's best interest. Getting people to have a healthy and good life in their community is really important. And we are not bringing people out unless we make sure that we have got the right care packages, the right support, and everything being there. It is often more expensive and a real about providing the community care. But we are all, health and county councils, community, local authorities and so on, absolutely committed to enabling people to live in the community. So there's a real focus on doing that and giving people the best care. In terms of your other questions about why on leader and why aren't health checks doing, I think one of the challenges and one of the things for us is every service is busy, every service has got a real challenge on things. And actually what we're doing today and what we've been doing elsewhere is shining a real light on this vulnerable group who often don't have the opportunity to champion things themselves. And that's why we're driving that bit of performance through to get a real focus on delivery. There's an awful lot we've still got to do. So solving the challenges around BAME access and why and support and why there are different levels of service are real things that we've got to do. But I was with colleagues, we were talking to national colleagues about how LLR could be leading this way forward and delivering things on it. So I think we'd recognise a lot of the challenges. There's a lot that I've sort of shown you on the data. I think the data is showing that we're making a progress, and it's just about keeping going at it. And our challenge today is to get you all to talk about it, because that actually helps us in the delivery of where we're going. If you're all aware of what's going on, everything you're sharing will help us generate and build a lot more support for people with learning disabilities.
And carers.
And carers, absolutely. Yeah. I'm not sorry, by not including carers, absolutely. And there has been additional stuff that particularly Leicestershire County Council has been leading on in COVID to ensure that carers are being supported. So we're not looking at leaving carers alone during this period of time.
This is not her lived experience.
Yeah, I reckon. Yeah.
This is in Rutland, and her lived experience is that she and others, and she's been picking this up from Carers UK as well, so it's not just Rutland, it's national, that carers are not getting the support they're needing. The support services, a lot of the groups that they go to, etc., have stopped during the pandemic, and the carers are picking up that slack, and they're absolutely exhausted. She's telling me, she said some of the things that she's hearing are that just make her want to weep. They're so sad. So that's her message. I'm trying to pass on.
I think I don't know, Councillor Underwood.
Sorry.
Okay, well, Miss Underwood, if you get I'll contact you and I'll relay that back to Kim or Mark Andrews or John Morley in Rutland, because obviously we've got to understand what's happening for that particular carer and her son-daughter. Just to add, and I will address that with colleagues from Rutland straight away. The autism board that I chair, we kind of suspended that with COVID, and we had the first one yesterday for some time, and where we're launching a website which was very well received. We changed the timings of that autism board to make sure carers can join it, and I'm just wondering whether this individual just resonates with me. So I'll address that via colleagues. As David says, LLR's response to the terrible impact of COVID around supported living and for this highly challenged set of service users was actually quite praised quite considerably for its effectiveness. But I accept we can do a lot more. And if you give me those details, I'll refer it to my colleagues in Rutland. Okay.
Thank you.
Very much. Need to obviously move on as soon as we can to the next paper. However, Amanda and then Melissa.
Thank you, Chair. Apologies, this is a sort of a bit of my, it's an area that I'm interested in, particularly working in the sector, but there's just a couple of points, more general really, is that the health checks, I think the concern I've got is 1920's performance is 53%, which means 47% of people didn't get a health check. And we're also expecting 33% of people won't get a health check in this current year as well. And I think actually the concern is not about those that do, the ones that don't, and how regularly don't they get them, and how are we looking at that. In terms of the led a review, I understand that Leicester was part of the pilot for the initial setup of the review in terms of the audits of reviewing people with learning disabilities and understanding the details of how that death had occurred. What did that tell us locally against the other areas in that particular pilot? The 59 years with Councillor Parton mentioned it earlier. How has that changed over time? And is there a sort of a public health piece of work that needs to be done? Maybe brought that forward. And finally, the concern I really have though is with the vision, we talk about communities with access to the right support. I don't think it can go unnoticed, and certainly working in the sector, this has been my personal experience, that support packages for people with learning disabilities have been reducing considerably over a period of time. And that's obviously, not anybody's, from the guys that have come today, it's not your fault, because obviously this is about how public sector is being funded, and reducing care packages is something that's happened during austerity. But actually, what part has that played in the long-term care of people with learning disabilities, and are we now seeing the impact of that? Okay,
thank you. Peter, if I pick up the first two annual health checks in the leader pilot, if you could pick up the last one. Sorry, Councillor Hack, I missed the bit about the public health and 15 years.
59.
Oh, 59. Oh,
yeah,
okay, right, that's where I missed it. Okay, has it changed over time? Okay, thank you. Right, so in terms of annual health check, I'm with you. If we can deliver greater than 67% and actually acknowledging and making sure that we don't miss anybody, that would be good. That's the goal to aim for. The reason 67% is there is a recognition from NHS England on a national target and a national delivery for working things forward. There will always be, and we have to accept, there's an element of patient choice in going forward and taking an annual health check and working things through. And we have to make sure that we have the right dialogue and the right support with people to make sure that they understand the importance of where it's going. To do that, we've specifically focused an extra project on people who haven't had their annual health check for 2 years, so that we will focus deliberately on the small population where that happens in order to explore the reasons why and to support them. Is it about going to a different venue or something else that's working there, so that what we don't have is a group of people who then just get missed out. So we're working through that and delivering on that. In terms of the leader pilot, I think the best bet would be I'll share the LLR link for the public leader document, and we've got the national leader document. The key themes that are coming through from it are very, very similar. So there isn't something that says that there's something particularly going wrong in LLR and not elsewhere in the country, and then something that's going really right in LLR and not elsewhere in the country. They have common and similar themes. And a lot of this is just about general ways of working and making sure that we all follow the systems, the processes, and the individuals don't fall down gaps between organisations. And then I think in terms of where we are around the 59 years and any change over time, we've had leader reports nationally for a couple of years, but this year is the first year where each individual system has been asked to produce its own analysis and leader reviews. So there isn't a back story of looking about how mortality has changed over time. There's nothing that I would know particular to LLR that would tell me that it suddenly got worse or suddenly got better. My expectation would be it's been about the same. But that's one that we will build up over time as we get more information, and we're looking at this more often. And Peter, do you want to touch on?
Yeah, absolutely. Packages? Just on the point about community involvement. I mean, we know that, for instance, in autism, around the issue of support with community support, we're doing some really great work around autism-friendly communities in Kegworth, and I think my ambition, my drive would be, let's do that in every community across LLR. I know, for instance, in the city, they have a Monday club, and I've been invited to go, but pre-COVID, I couldn't, to see what work they're doing, and I'm sure Rutland are doing the same. On the point of spend, and I take the point, and I think, actually not taking responding in terms of politically austerity or COVID has probably made a big challenge around supported living and working with providers, but the basic principle, and this has been going on certainly before 2010, was that progression planning for adults with learning disability and complex autism was that a community supported setting is far, far better than being in a residential placement, and not just from the cost perspective, which can be eye-watering, councillor. I mean, I'm sure you know, £6,000-7,000 a week. Well, I would rather, as a senior officer working with the politicians, drive it to drive all that resource into the community and have community supported packages, because you know you're going to get better outcomes. And that's a national agenda. It's a local agenda across LLR, and we continue to strive to do that, to build. And this is the part of this fit trajectory is about connecting. We've had 2 forums now where we've connected with the providers, trying to work with them, trying to get them to understand the dilemmas that we've got, and create wraparound community-based living for these people, human beings, you know, and that's what we strive to do, instead of highly expensive placements, which often the outcomes you'd think, well, what are we getting for that amount of spend? So no, specifically, I don't think austerity has exasperated it. That's our plan and the mission that we continue to go on.
Lovely, thank you.
Chair, I think you're on mute.
I am. Oh, that's interesting. Didn't know that was happening. Need to move on fast as possible, but please, Melissa, your question.
I'll be as quick as I can, Chair. Thank you for this. I guess a few things struck me as really quite stark in the presentation, and then when you were talking to it, you talked about winter-born view, and you talked about then there's the very stark quote just from April this year. So there's 9 years there, and there's still an awful lot of work to do if the position is as stark as it was in April. And then also, you know, there was some conversation about a prime minister and there's been 2 more since. So you know, there's quite a lot of time elapsed, and yet but actually perhaps not the kind of progress we'd all be wanting to see here happening. So obviously really welcome this, but I guess my question, in the 12 years somebody spent in hospital as well also really kind of struck me. I guess my question is that I feel like that there's still clearly more work to be done here, and welcome the way in which you're talking about it, and clearly there is work going on, but I'd like to maybe see some more detail, and perhaps come back to this in a future meeting, Chair, if that would be okay, perhaps with some more detail about how we're progressing and the impact COVID was having and those sorts of things, please. Thank you.
Thank you.
Can I just to respond very briefly? Yes. Thank you, Councillor March, really helpful. And one of the reasons for wanting to come here today is that we've taken a deliberate approach that in LLR we're talking about it. We're going to open this up. We're going to make this something that everybody can solve. We can't do it on our own, and the data from history shows that actually we haven't made the difference. So today is part of coming together and doing that call to action, which says, actually, we all want to talk about getting learning disability, people, service users with learning disability, really good care in the community. And by coming to places like this, actually, we can champion it, and we're happy to come back.
And just to add, I mean, no, it's not acceptable, Councillor Marsh. No, the history of service provision for adults with learning disabilities goes back probably to 1900s. And I started my career 30 plus years ago, and I remember down in Croydon, there were kind of each city and probably county would have a community, these huge, great big hospitals. We all know them, don't we? And they were there where these patients were just left. So that's the history of it. It's not acceptable, and that's what we're doing in terms of this call of action to modernise it, drive it forward, and make the changes that are required.
Yeah, thanks very much.
And thank you. And could we come back to this, please?
Oh yeah, absolutely. No,
thank
absolutely.
you. Thank you.
Thank you very much. Right. Dare I say it, this is probably the main report that we've got today, not discounting any of the ones we've obviously had up to this point. So item 9, building better hospitals for the future. We have, I said earlier, we've received a representation on behalf of 20 members of the public. Although I'm not taking that on board because it came too late. Again, if members wish to read it and take the points up that they've raised, by all means do. Andy Williams, are you going to lead on this?
Yes, thank you, Chair. And I'm joined by Rebecca Brown and Mark Whiteman to talk through the presentation. We have other colleagues available as well, including Richard Morris, who from the CCG may well be able to help us with the detailed issues around consultation. But yeah, let me lead off, and then I'll hand over to Rebecca and then to Mark, if that's okay. So I should start by saying, really, it is a pleasure to be here. Actually, it is really nice to have the opportunity to come to this committee with finally specific proposals and the beginning of consultation around a colossal investment in acute and maternity services, £450 million for this area. And these occasions really don't happen very often. So it's a real joy, actually, to be able to say that we're now planning in earnest and really able to get going with this kind of transformational investment. It's a particular pleasure because although I'm relatively new to the area, I do understand that this has been a long time coming as well. And there's a lot of work over many years that's led us to the position where we are now really seriously able to start to make this transformational investment in services locally. So understandably, we're really excited about that with the health service and many of our partners. That doesn't in any way mean that we're unsighted on the fact that investment on this scale means change, and that those changes impact differently on different communities and different people. So we're very conscious of that, and through this process of engagement, we're really determined, with your help, to get as deep and as broad an engagement with the community as we can, so that we're absolutely sure that as we finalise these proposals and at the point they go forward and perhaps get signed off, we're making those decisions with as complete and as meaningful an understanding of the issues and the impacts they have on communities as possible. So that's the essence of what we're going to do. We're going to take some time to run through the proposals, and we can also describe a little bit about the process of engagement, and then obviously we'll do our best to answer any questions, but also just to listen to the comments. Not every comment needs an answer, and we're happy to listen where there are answers that are needed or can be given. We'll do our best to do that. If there are very specific things we simply don't know, we'll just say so, and we'll go away and find the answers to them if we can. So with that introduction, and hopefully with that sense of the opportunity we've got, perhaps I could just ask Rebecca to say a few words, and then I think we're going to ask Mark to take us through some of the detailed proposals.
Thanks.
Thank you.
Thanks, Andy. Rebecca Brown, Acting Chief Executive here at University Hospitals of Leicester. So again, a great privilege to be in an chief executive position during such a really, really exciting time. And I know all of us as leaders in Leicestershire, Leicester, Leicestershire and Rutland, it is such a great opportunity for us. So, you know, the excitement, I know, it is building. But of course, it's not just about the investment, it's also about the transformation of clinical care. And that's really such a very, very important part of this programme. We're very, very fortunate in LLR to be on the cutting edge of a lot of medicine, something that we all should be very, very proud of, and we want to see that going forward. So this is, again, really helps us with our position. It is also coming at a time when actually, you know, with COVID being as it is and the impact on the economy, knowing that we've got this investment coming into our city to support us with our economy, you know, utilising and involving our community is very, very important. And of course, our businesses. It is an opportunity for all the leaders across LLR to be involved, and that's why this consultation is very, very important. And of course, you will help us because, of course, you have so many people speak to you, and you will help shape that. So it's such a wonderful opportunity for us to be here. I also just want to pay a bit of homage to the great team that are behind the scenes that have made where we are now happen. We have a dedicated team within University Hospital of Leicester, but we have also a wider system team, including LPTs, the CCG, primary care, and University Hospitals of Leicester. And they're all working together to absolutely make this exactly what we need. But we can't do that in isolation. We absolutely need our public, our patients and our communities involved in this process. So I will hand over to Mark, who will give you the essence of this presentation. Over to you, Mark.
Thanks, Rebecca.
Thank you both. Could you just give me a shout when you can see the slides, please?
Yeah, they're up, Mark. Thank you.
Brilliant. I need to repeat myself or repeat what Andy said. After years and years and years of me coming in front of the joint HOSC and individual HOSC saying maybe next year, maybe next month, maybe at some point, I'm really chuffed to bits that actually what was previously a bit of a pipe dream is now a reality. So forgive me if I come over as a little bit like a bouncing puppy on this. We really are genuinely excited about these plans. So just to walk you through it, this, believe it or not, is the 72nd year of the NHS being in existence. In terms of our own hospitals, we've been around for 252 years. Clearly, a lot has changed in that time. One of the major changes has been the increase in life expectancy for your average member of our population. So a bloke can now expect to live till 77, which is 10 years longer than in 1948, and a woman even longer. But within that is one of the issues that the NHS and social care faces, which is namely that actually as people live longer, they're living longer with illness and infirmity. So there are more of us now than there ever was, and we pick up illnesses as we grow older. And we expect more out of the NHS than we ever did before. To its credit, the NHS can do more than it ever did before. So as an example, at the Glenfield Hospital, we routinely now operate on 90-year-olds with heart valve replacements who 10 years ago would not have survived major surgery. At the same time, you read about in the press, every winter is deemed to be the most challenging on record, and it's highly likely actually that will come to fruition this winter when you factor in COVID. And of more concern perhaps for everybody involved in the NHS and social care is the fact that actually winter is no longer winter. It seems to last all year round. So all year round, GPs, hospitals, walk-in centres, and indeed adult social care, it feels like winter all year round. But before it gets too depressing, let's just remind ourselves that the NHS is still a cherished national institution, and it perhaps is the last of the cherished national institutions. So despite what we read in the papers about cash crisis, not enough nurses, not enough doctors, every day you know that the NHS saves lives, brings babies into the world, fixes broken bodies, and where we can't do any of that, we try and give people a good death, as well as at the same time dealing with a pandemic. We hear a lot about things being better in other countries, you know, cancer survival rates in Sweden and Denmark, waiting times in Australia. But every day of the week, somebody from one of those countries will be in some NHS trust trying to find out how the NHS
does so much with so relatively little in terms of its share of GDP. So yes, we'd like more money, yes, we'd like more staff, but in the meantime, we're doing our very best with the money that's allocated. Fact is, though, we know we can do better, and actually you and our patients tell us we can do better. And these are some of the things that the patients tell us. And the reason I'm showing you this or reminding you of this is actually this is the thing that sits behind our reconfiguration plans. So our patients say that it's the gaps between services, especially when patients are discharged from hospital, frustrates them, the difficulty in seeing a GP, the fact that within a hospital, patients are pinged between different parts and different hospitals for different parts of their treatment. There are long waiting times for certain hospital appointments, cancelled appointments and operations when winter pressures kick in, and constant repeats of name, address, and NHS number. I guess that my take on that is it's rarely the individual patient contact with their consultant, their nurse, or their GP that frustrates people, but it's how it all fits together that kind of makes people and the public kind of frustrated, which is one of the reasons why we're so keen to sort it out. Why do we need to make the changes? Well, before answering that, I guess it's just necessary for a quick history lesson. And the history lesson is such that our three hospitals didn't exist as a trust before the year 2000. In the year 2000, the three hospitals in Leicester, the General, the Glenfield and the Royal, were merged to form UHL. And whilst the merger was in many ways successful, one thing wasn't tackled at the time and hasn't been tackled since. And namely, that is that actually our clinical configuration is more an accident of history than design, such that it was only until very recently that you had the cardiac and the vascular service put together at the Glenfield. Previously, they were a mile and a half apart, one at the Royal and one at the Glenfield. And that means we have split site working, we have replicated expensive kit spread across 3 sites, our staff are duplicated or triplicated, and that's really difficult to manage in steady state, not to mention when you're in the kind of the teeth of a pandemic. And it's also really expensive to run. As colleagues will know with long memories, our first attempt to sort this out hit the buffers in 2007. It was called Pathway. It got way too expensive and we canned it. Excuse me. But as a consequence, when all the other acute trusts, in fact, 2/3 of the acute trusts up and down the country, were then getting investment, UHL, Leicester, Leicestershire and Rutland missed out. And that's got to change, and it has changed, thankfully. We're one of the biggest NHS organisations in the country, and as Rebecca was saying, some of our clinical outcomes in key services are not only the best in the country, but some of the best in Western Europe. And yet we are operating out of buildings that, well, our oldest building is 252 years old, and we're still running clinical services out of it. So when the government announced, I can't remember what it was now, but I think it was in the autumn of last year, that we were one of the successful schemes to get the thick end of £500 million worth of investment, we were clearly delighted and excited. So this is the plan, and it's something that should be familiar with you all, but I'm just going to refresh your memories because actually you're not as close to it perhaps as some of us. So the core of our long-held clinical strategy is to separate emergency and elective, i.e. non-emergency care. And the reason for doing that is that when emergencies are normally running hot, they sometimes mean that we are cancelling elective care. And that's not good for patients, and it's not good for our staff. We've seen in recent winters the cancellation of operations and the impact that has on patients. And that will only get worse for as long as those two flows of patients stand together. So one of our key objectives is to separate those patient flows. And in doing so, we will be building a treatment centre. We've got to find a better name for it than that. It's more exciting than that, at the Glenfield Hospital. This will be a one-stop shop for those people who are non-emergencies. They'll get their pre-op workup, they'll get their diagnostics, and then they'll get the procedure on the same day. And that will enable us to kind of keep that work going, regardless of what's happening in the rest of the emergency hospital. To give you a sense of the scale of that, this picture shows the new treatment centre with the older bit of the Glenfield sitting behind it. And you can see it roughly adds about 50% onto the current size of the Glenfield Hospital. So it's a really, really significant build. And as I say, it's right at the core of our clinical strategy. Within that, we'll be doubling our ITU capacity, intensive care capacity, which I'll come on to in a minute about why that's really important. But the key element of it is it enables us to keep our elective work going, regardless of the other stuff that's happening in the epidemiology of pandemic or whatever else it might be. If I go on to the Royal Infirmary, so the key element of the Royal Infirmary in the building you can see here is that we want to bring together all our maternity and children's services. That includes neonatology at the Royal Infirmary. Currently, those services are split between the General Hospital and the Royal Infirmary, and we struggle to cover both services when both services are running hot, both in terms of consultant cover, nurse cover, and most particularly neonatologists. It's not good for safety, it's not good for sustainability, and the CQC on more than one occasion have pointed that out to us in no uncertain terms. What that means to patients and mums who are delivering is that if they've had all their prenatal workup at the Royal, they may get transferred on the day or within the hour to the General, to where they weren't expecting to give birth when the Royal's running hot, and that happens the other way around as well. So we're bringing those two services together, or we'd like to bring those two services together at a new maternity hospital costing about £88 million at the Royal Infirmary. And that would allow us to have obstetric-led birth, a midwife-led birthing unit next to obstetrics in the same building, and every side room would have its own birthing pool alongside. And that means we can bring together the staff, bring together the expensive kit, and bring together neonatology in such a way that if something does go wrong, we're on hand to sort it out. One of the key elements of the consultation, though, is, as you know, we have a midwife-led birthing unit in Melton Mowbray. It currently has one birth every 3 days, which makes it unsustainable in the longer term. And actually, it's difficult for people to access who aren't in the immediate postcodes around Melton. So the proposal is, subject to what the public think and want, that we will bring that midwife-led birthing unit from Melton to the Leicester General Hospital, where hopefully it will be accessed by more mums exercising more choice. The last thing, not the last thing, one of the last things on the Royal is I mentioned increasing the numbers of ICU beds at Glenfield. We will also be doing that at the Royal, such that eventually we, at the end of the plan, will have doubled our ICU capacity from about 50 beds to 100, which is really important when we come on to talk about COVID. Last but not least, on the Leicester Royal Infirmary is the Children's Hospital, something that's very close to my heart as the kind of the lead for this project. We have the biggest children's service in the East Midlands. The East Midlands doesn't have a standalone children's hospital. You wouldn't know that Leicester had the biggest children's service because it's dotted around the hospitals. Now, it doesn't mean that clinical outcomes are poorer, but it does mean that if you're a little fella or a little girl coming into the hospital, you are sitting cheek by jowl as you walk in the door with adult emergency patients. We don't give people an age-appropriate environment, and we really like to, because actually hospitals are scary places for most people. They're especially scary for children. So the Children's Hospital build is taking place at the moment. The first element of that is the co-location of East Midlands Congenital Heart Centre. As I look out my window now, I can see the cranes. It's really exciting, and our vision is that we do something really remarkable and really kind of age appropriate for our smallest patients through the creation of the Children's Hospital. This slide just shows where all those things sit. So this will become the new Children's Hospital. Currently, that is our maternity building at the Royal. When we build the new maternity building over here, all the mums from there go to here, and that then gets converted into a children's hospital. And this is our new ICU, which will be sitting on or around the new A&E. I'm nearly there. Those of you who are kind of getting presentation fatigue. Leicester General Hospital. So by the end of this plan, Leicester General Hospital will no longer be an acute site. It will be a community campus, still important in the kind of the sphere of the overall offer for the NHS in Leicester, Leicestershire and Rutland, but its focus will be on community health and primary care. The services on that site will be Diabetes Centre of Excellence, a GP community hub with on-site diagnostics, so GPs can use diagnostics without pinging their patients into the Royal Infirmary or into the Glenfield, a bit of a one-stop shop up there. It will have the inpatient stroke rehabilitation for people who are stepping down from the acute but need rehab post-stroke, the midwife-led birthing unit, the city crisis response teams, and some back office functions. The land that frees up as a consequence of consolidating those services into the community hub will be sold for housing for key workers and affordable housing, and that money will be reinvested back into the NHS. Overall, all those plans come to about £450 million worth of investment. That's an eye-wateringly large sum of money. I appreciate that, but actually it costs us about £2.5 million a day to run Leicester's hospital. So we think it's good value in the long run. I said at the start that I need to talk about COVID because one of the questions we're bound to get is, has coronavirus changed our thinking? Well, we thought it might do, but we tested that with our clinicians, and there's 3 or 4 things I just want to share with you very briefly. So before COVID hit, as we were preparing for the peak of the pandemic, the key issue was creating enough intensive care capacity for those people who needed ventilation. And as you know, the kind of operation to protect the NHS by social distancing and the lockdown, that was what it was there to do. We doubled our intensive care capacity, not because we've got lots of intensive care capacity spare, but because we converted every spare space, including operating theatres and step-down areas, into makeshift ITUs, such that we got up to about 100 intensive care beds. Now, as it happened, because of lockdown, we didn't need all those. But it was very, very scary for everybody involved in Leicester's hospitals at the time about the fact that we might be overwhelmed. The new plan gives us at least 100 new intensive care beds, and that doubles our capacity, which makes us pandemic proof for the future. Linked to that, in one of the things that we did, although we didn't like doing it in terms of clearing the decks for intensive care, is we converted our children's intensive care unit into an adult intensive care unit. And that meant we could no longer do children's heart operations at the Glenfield Hospital. So we transferred all that activity to Birmingham for a number of 4 months, actually, in fact, meaning that the very service we had fought to keep, we had to lose for 4 months in order to protect ourselves for COVID. If we'd had the children's hospital standalone with its own standalone intensive care unit, that wouldn't have had to happen. And then probably the most important bit around would our current plans protect us against future pandemics, whether it's COVID or some other nasty, is the idea that, as I said at the very start, the heart of our clinical strategy is to separate emergency and elective care. If we'd had the treatment centre at the Glenfield, we would not have been cancelling whole swathes of patients, including, sadly, some cancer patients, in preparation for what the pandemic held for us. Because that treatment centre would have been kind of a hospital within a hospital, we could have kept our elective services running. And then a final point to make, I suppose, in terms of the consolidation of services onto 2 rather than 3 hospital sites, is that during the peak of the pandemic, we were running at something like 1 in 5 of our frontline staff were off with either COVID or looking after somebody with COVID and therefore self-isolating. And that meant running 3 different hospitals with 3 different rotas was almost impossible at the best of times, but with 20% of our staff off sick or caring for others who were sick, I mean, we nearly fell over is the point. We got through it more through kind of grim determination than planning. There are bound to be questions on transport, travel and parking. This is a major component of the plans and a major component of what we want to hear from members about, but also from public. The headlines are broadly that for 70% of people affected by these changes, their journey time will either reduce or at the very least stay the same. But 30% of people will have a longer journey time, although not by very much. We know that matters to people. We know that car parking, as an example, matters to people. So we'll be investing in car parking as a consequence of this. And also for those people, especially those people in the city who are worried about car parking at the Royal, one of the key things to understand is actually a lot of the traffic that comes into the Royal Infirmary by dint of us moving activity away from the Royal Infirmary to the treatment centre at the Glenfield. We will actually decongest the Royal Infirmary site. I'm trying to think where to go next. This is more for the public than for yourselves. We may want to pick up how we're going to approach consultation. We can do that in the questions. But I think at this stage, all I wanted to show you was just a reminder of what the plans were. So in summary from me, exciting times or maybe frightening times, depending on your point of view. This is nearly £500 million worth of investment in your local NHS and the local area, as well as job creation for local businesses and the local economy. Let's be frank, it's about time. We've been talking about this for literally decades, but I'm now boring myself, so I'll shut up and I think we're going to open it up for questions.
Thanks very much, Mark. Thanks, Andy and Rebecca as well. Right. Sam Harvey, I think is the first one.
Thank you, Chair. I've just got a couple of questions. It is a, we all do appreciate it's a really exciting project. But there's obviously, I'm going to highlight transport. You yourself highlighted the issues around transport as a prohibitor to the St Mary's site. So my question would be, how are we going to mitigate for all the population? And I appreciate it's only 30%, but for how are we going to mitigate against the populations on the outskirts of Leicestershire and Rutland? But also, I'd really like to see some numbers on how many parking spaces are you creating? Because whilst the treatment hub at the Glenfield looks fantastic, by moving all of the people from the other two sites into the Glenfield, we all know that parking around the Glenfield, if you cannot park on the hospital site, then you can't park because there are restrictions everywhere there, which means it will make it impossible for people. And 30%, I would argue that 30% of the population you're talking about, it is impossible for them to get public transport to the site, even with the hoppers and stuff, because you cannot expect people to be looking at 3-hour journeys each way from outlying villages and stuff on the outskirts of both Leicestershire and Rutland. And my final question goes to the consultation and just an inquiry. Obviously, we were informed previously that the 16-page leaflet would be coming out. I am conscious we're nearly a month into the consultation process, and so far there doesn't seem to be, certainly within Rutland, many people who've received that. So I was wondering when that brochure is actually coming out. Thank you.
Thanks, Sam. Who wants to answer that then? Car parking seems to be the big one, doesn't it?
So, Andy, are you going to direct questions to who you think should answer them? But shall I just kick off with a bit on car parking?
Yeah, sorry, Mark. Yeah, please do. I assumed you would naturally step into that question. Sorry, I should have said. Yeah.
So, Councillor Harvey, thanks for the question. As I said during the presentation, the transport and travel element of this is one of the most important elements, because I absolutely get it's pointless building fantastic new hospitals for our local population if they can't access them. In terms of car parking, we are significantly increasing our car parking provision. A lot of that will go at the Glenfield Hospital. If you can bring to mind, but I think you've got it in your packs, the picture of the treatment centre. You may remember that in front of the treatment centre is a one low-level car park. To the right of the treatment centre will be a new multi-storey car park. The low-level car park, if it gets overwhelmed, we have the ability to go up even further on that. I hasten to add that at the same time as we're doing that, we're also balancing off our commitment to a kind of low emissions economy locally, talking to local councils, including the counties and the city, around what the green travel plans are. All of this will out through the consultation and through the work we're doing with communities, with Health Watch Rutland, Health Watch Leicester and Leicestershire around the travel plan. But I think there's more work to do than has been done. I recognise that. But in terms of the kind of the the hard currency of car parking will be increasing it.
Okay.
There's something around the leaflet, Andy.
Part of the question. I'm conscious we've got Richard Morris with us from the CCGs, and Richard has done a great deal of the work on the consultation process. So perhaps with your agreement, I could just bring Richard in to talk a little bit about that, and in particular to the question around the leaflet.
Yeah, thanks very much.
Hi, everybody. Thank you for that. Great to be with you. So the leaflet which is being referred to looks like this. It's actually 8 pages long. We're now 2 and a bit weeks into the consultation process, and delivery of the leaflet is ongoing. We had hoped originally that the distribution would be completed by the end of the 3rd week. We suspect it's probably now going to run on a little bit beyond that. But we know from talking to lots of people and seeing lots of posts on social media that many people have received that leaflet. Certainly we know at the moment that the PE postcodes in Rutland haven't yet been delivered to. That's still ongoing. It isn't quite as easy as me being able to tell you, for instance, that it's been delivered to everybody in Market Harborough, but not yet in Lutterworth, because it doesn't tend to work in that way. The way that the distribution company is working, it's delivered in towns, almost on a kind of phased basis, effectively. So even within some urban areas, some people will have received it so far, other people might not. The process is ongoing, and people should hopefully have received it by the end of next week.
Sorry, Chair, can I just come back on that just for a second? I was obviously, it is really important, and whilst I appreciate there is lots of chatter on social media, and that's great that we're pushing it out, we obviously, sorry. There is what I'm trying to say, there is obviously, we do have an older population, and there is issues around not being able to access the internet and stuff. And actually we know this is a very long consultation document, and so if we can try and get it out as soon as possible, the hard copy, to people so that they can actually digest it. But what I was are we able to come back to you, say, in 2 weeks if we're still hearing that it's not out in our areas?
Yeah. Of course, Councillor Harvey. In fact, I'd really encourage you to do that, actually, because that would be really useful feedback for us. What I would say is clearly the leaflet is really important to us in being able to be confident that we've reached everybody across LLR. It isn't the only tool that we're relying on, though. So, of course, we are still using traditional media, both print and broadcast, as well as some of the local community radio stations, particularly those that tend to broadcast in languages such as English, to make sure that people who perhaps don't have as much access online aren't left behind, and they've still got opportunities to find out about the consultation process and take part in it if that's what they wish to do.
Yeah, thank you. Thanks very much, Richard. Thanks. Gail Waller.
Thank you very much, Chairman, and thank you, Mark, for your presentation. I'm sure we all welcome the money being spent on the hospitals, and we recognise the problems that you've currently got. I do have 1 or 2 observations, though, as well as a question. My first is picking up Sam's point about transport. From large parts of LLR, getting into Leicester is well nigh impossible by public transport, let alone getting from there to the hospitals. So people are reliant on cars, either their own or using one of the voluntary systems. And so I would urge that the first bit of development you do is building the car parks, not waiting until you've got all the health facilities in place and then doing it last. Because if people can't access it, they won't. And I hope this isn't a quiet way of trying to persuade people to go to hospitals outside the area. That's a tongue-in-cheek, Mark. Secondly, just an observation, there are a number of references here, and indeed into some of the other health documents we've had this morning, to the Council of Faiths. I have been in conversation with the Rural Dean in Rutland, and she assures me that Rutland is not part of the Council of Faiths. And so if you are wishing to communicate with churches in Rutland, you may need to use a different route. She did sit in on some of the COVID meetings, but Rutland isn't officially involved. That's just for information. My third one is a question. You refer to digital and total triage, and I'd like to know what you mean by that, because to me it says you can't come and see a real clinician at all until you've been through this system, and the idea of it is to keep you away from a clinician. Now, I do understand what the words individually mean, but I would like to hear a bit more about that. I'll go through all of mine before we come to an end. I come to an end. I would like to make an observation about midwifery. I'm not sure I'm going to be totally popular, but then I'm not sure I particularly care about that, because what I'm saying is from the heart. I understand your argument that if a mother is in a midwife-led unit and has difficulties, transferring some miles to specialist care is not good. And anecdotally, I can speak from experience, having been in last stages of labour and having to be travelling in an ambulance is not a pleasant experience. And I went through this nearly 30 years ago, and it's still indelibly etched on my brain. So total sympathy with the view. What I don't understand, though, is why you would then want to create a midwife-led unit at the general, rather than having enhanced midwife-led unit, enhanced as in size, at the Royal, if that's where all the facilities are going to be. Because a mother in labour travelling from the general to the Royal is just as uncomfortable as travelling from Melton to the Royal. And it seems to me that there's the potential to invest a lot of money in a facility at the general that won't then, after a year or so, be proved to be viable and will be closed. And I'd rather have the investment in the Royal up front. So that's my personal observation on that. And my last point, and this I think is as much directed as at our chair as it is to you, Mark and Andy, and that's throughout this paper, and indeed all that we've heard about reconfiguration, there are references to wider community provision, whether it's hydrotherapy pools, whether it's dialysis units, whether it's treatment centres elsewhere. And all of that requires other parts of the health service to deliver. And I am not confident at this stage that the other parts of the health service are geared up to deliver, whether it's in our community hospitals, whether it's our GP practices and so on. And I want to understand a lot more about that. And I'm wondering, Chairman, whether that might be something for our next meeting. And that's all I want to say on this at this stage. Thank you.
Thanks, Gail. I mean, I can answer that last bit, I think. I'd point you to Andy Williams on the basis it's the CCGs who are running this. And obviously the CCGs are now coming together across LLR, and therefore they're the cement, if I dare call it that, or the glue that holds it all together. And they're obviously looking at community, GPs, UHL, the whole lot. But anyway, Andy, do you want to just pick up on that?
Yeah, thank you. And I'd be very happy at a future point, I think, to come back to this committee and indeed elsewhere to talk about the overall kind of clinical vision. And how the other parts of the system we hope will change and develop. A couple of things I would say is that we are already investing considerably in primary care and in PCNs. We've got substantial investments going into aspects of mental health and well-being. That process, of course, needs to continue. These plans themselves will take several years to implement. So, I wouldn't want to create the impression that we've got absolutely everything in place right now when we're just waiting for the buildings to go up. But equally, I wouldn't want you to think that that there hasn't been an ongoing process. So probably the best thing to do would be to kind of, with your agreement, think about how we bring that other conversation into this space at an appropriate time, and I'd be really happy to do that. Just picking a couple of the other points up, I'll pass to colleagues, perhaps Rebecca in a moment, maybe on the midwifery issue, although it was very interesting. We actually had a virtual public meeting yesterday and heard with tremendous passion, actually, and enthusiasm from some of the midwife leaders about, why this balance and maybe the general is worth a try. Although I take the councillor's point entirely. I think so. Rebecca may wish to talk a little bit about that. The total triage point, I think, is really quite an important one, because I understand the suspicion, and I can see that it could create that kind of fear. But in fact, the point, certainly in primary care, of trying to embrace triage is actually to make sure you get a clinical conversation earlier rather than later. So what we're trying to do is to get to a position where we get a clinical interaction, often virtually, maybe a phone call or a face meeting, so that the clinician has a clearer sense, the doctor that you're speaking to has a clearer sense of where the right service is. What we've got at the moment, and it's true in primary care, it's true just a little bit of the NHS, is that there are a series of thresholds that a person goes through before you end up sat in front of the specialist. So you might talk to you might have to book an appointment, you might have to go through a receptionist, you might then get to see a nurse, you might then see a doctor, you might get a referral to a specialist, and so sometimes that process has multiple steps in. What we're finding with total triage, and the reason we're keen to explore it more, is that it's often faster to put the senior clinical decision maker, the doctor or the most experienced clinician, at the front of that process. So that if the person really can self-care with advice and support, or maybe get some support from a pharmacist, or perhaps only needs to see a nurse, we can direct them there straight away, and they get that care straight away. Equally, there may be other people who immediately need to see the doctor, and in that case, that triage process can facilitate that. So we actually, it's designed, and we hope and we think it will actually speed up the process of accessing the right response, rather than slow down access to a clinician. But it is new, and I guess we do have, with your support, to work that through with our patients, with service users, to help make sure we get the best out of the service. But we do believe that it will ultimately help us to be more effective in caring for patients. Perhaps I could pass to Rebecca, maybe just to kind of pick up on this wider issue about midwifery and where services are in respect of that.
Yeah, absolutely. Thanks, Andy. So the plan for the LRI maternity and women's hospital absolutely will have in that its own midwifery-led birthing unit. So it will have that facility if people choose that facility. But I think it's also important to recognise some of the wonderful aspects of the Melton St Mary's unit, and making sure that we are utilising some of that aspects also for a greater cohort of women, because I mean that is the key thing about the Melton unit, is that actually it is a wonderful unit, but actually it isn't able to be offered to a lot of women. Moving it, if it's agreed through the consultation, and having it at having a trial to having it at the general, I think will give us that opportunity to see how our public, our women, are choosing around their birthing decisions. But of course, we're also, alongside this, really going to promote, where clinically appropriate, home birthing and community care. So there is that also going on in the background that is also part of this programme. So I absolutely understand what you said, and I think it's about giving women choice, and I think this opportunity that we put together here will give women the best choice for LLR.
Chairman, can I come back on that, please?
Yeah.
Thank you. My point wasn't not to replicate Melton. My point was replicate Melton within the Royals site.
Yeah.
And so there is still choice,
I think
location.
Yeah, one of the things which we've thought really hard about here is, in theory, a great service offers 4 experiences. So the obstetric experience, the home birth, the co-located midwifery-led, and a standalone midwifery, and it's that last one which has always been a little controversial for exactly the reasons you've described. It's why I think we've described a cautious approach in the consultation to say, look, we really do want to get some feedback on this, and we also need to be really clear about, in advance, up front, so there's no ambiguity, what success looks like, because it's not an open and shut case. I think different areas have explored this, and if it's something that you'd like more information on, then we have got 1 or 2 focus discussions that are specifically honing in on this, where we'll have the midwifery staff themselves and some of the clinicians, the obstetricians, and that might give you a chance to explore it in a bit more detail as to why it's felt to be worth looking at, despite the kind of concerns that you've raised, which I absolutely, I think we all understand the points you've made, but I think the commitment is there to say our desire to try and offer this service to women, if it's appropriate, means that we at least want to have a go at doing that and see if it really can work. And there's reasons to believe it might. So I think at the moment our feeling is it's worth exploring. But this consultation exercise will help us, finalise that thinking, really. And it may be that the reaction means that perhaps we do have to reconsider that. But let's see what the consultation brings.
Thank you.
Yeah. Thank you very much, Gail. Ted, you're the next one. And then Mrs. Page.
I've said this before, and I'm going to say it again. Mark has the most incredible way with words. Do you realise that? In 2007, we canned it. That's exactly what you said. So, to be serious, how does the plans now differ to what was planned in 2007? Obviously, you couldn't do it then because of funding, but is this an upgrade on what UHL tried to do in the past? And for clarification, the £450 million. Is the money you're going to raise through the sale of a part of the land at the general does the £450 million have to be found, some of that realised from the sale of land, or is that an additional sum? And how much are you expecting to raise from the sale of land at the general? How much land will be left? I mean, how much is it going to shrink by? And the final point is where you talk about on page 70, 71, 72 about where services will be located. Obviously, 2 big ones are not listed here, but fair enough, it does say at page 70, it is not a list of all hospital services. Psychiatry, Glenfield, but are there any building works planned for the Bradgate unit? And can you just talk about what will happen to the oncology side? Is it moved at all, or is it just staying exactly where it is? But as I say, thank you. But I as soon as I heard you say the word, we canned it.
Thank you. I'm hesitating to interject before Mark, so I think I might just pass straight to you on that one, Mark.
Thank you, Councillor Parton. I'm not sure whether that was a compliment or whether I'm going to get into trouble with my boss later on for using colloquialisms, but we did can it nonetheless. Yeah. So your question is essentially, how does the scheme differ now to the one we had previously? I'd say that actually the key difference between the 2 schemes is 10 or 20 years ago, when we were planning Pathway, the money in the NHS, it was all flowing into the acute sector. We were building bigger and bigger and bigger hospitals. And the downstream effect of that is, for the last couple of decades, mental health, community care, primary care has suffered as a consequence because the acute hospitals have sucked up all the investment. One of the mantras about this reconfiguration is essentially our job is to be big enough to cope, but no bigger than possible, no bigger than necessary. So that for me is a fundamental difference between the pathway program and our current program. So even though 10 years further on, you'd expect things like building inflation to mean that this program is more expensive, it's not. It's about half the cost, because actually we've changed the way that the NHS operates. Even in the last 10 years, more work is done out with the hospitals than has ever been done before, and that direction of travel will continue. So I think that's the biggest difference, is actually, if you take nothing else from the presentation, we don't want to build dreaming spires that look really posh but then kind of are slightly empty. Our job is to make the very best use of taxpayers' money and build hospitals that are big enough to cope but no bigger than necessary. In terms of the land sale, that will be additional to the 450 million of capital. I think the district valuer has put something in the region of £20 million value on that land. In terms of the amount of land, I think it's in the region of 33 acres, which a colleague has told me is roughly the size of 33 football pitches. For those people who live in the city of Leicester, you'll know that there's a chronic shortage in terms of housing of all types, but especially in terms of affordable housing. So, in fact, one of the things that we're expected to do on these big NHS reconfigurations is be able to describe how, as a consequence of reconfiguration, the wider society benefits in terms of things like housing and employment. So that's part of our plan. I think your last point was around the Bradgate unit, and I'm sorry about this, but we don't run the Bradgate unit. That is LPT and mental health. So I'm not across the detail on that, other than to say very recently they've just opened their new CAMS facility there, which is a fantastic facility for children with mental health, children and adolescents with mental health conditions, and so that's a latest piece of investment in the Bradgate unit.
We did hear just before you joined us, Mark, actually colleagues from LPT talking about moving away from dormitory style accommodation and those sorts of investments. So again, Councillor, if you particularly want us to look at the kind of capital detail of what's going on the mental health side of things, then I can take that away with colleagues, and perhaps David and Angela and I can come back and have a chat to you about that. But there is a distinct and clear commitment to investment in mental health services physically and in revenue terms as well. And we heard a little bit of that in the earlier presentations today.
Yeah, thank you. That would be helpful. Thank you.
Very handy. Melissa.
I was just typing something about the Bradgate unit, but I will. My question there and here, as ever, is about bed numbers. So can I explain where my confusion comes from? So I've had the leaflet as a city resident, and the leaflet and the papers under agenda item 9 talk about 139 beds, and that's the first time I've seen that number. But this one, this is the pre-consultation business case, and the number that we'd been using until we had sight of that was 300. So there's a big difference in there between 300 and 139. And then within the pre-consultation business case, apparently of those 300 beds, 230 will come from efficiencies, because we're going to just do things different and better in the next 3.5 years. And then we'll have to apply for funding from the capital resource limit for the other 70. Is that? And then we'll find some more for 28 by doing stuff differently at the Hampton Suite, and 41 from some non-clinical space. forgive me for being confused. I'm okay with numbers and I'm okay at reading, but within this, I'm getting lost. And I keep asking the question, I keep not getting clear answers to this stuff. So please, can somebody be really clear about how many more beds tangibly we're going to see as a result of these changes, and how many of those are actually efficiencies? And given that we're halfway to 2023 now from when this was done, is it reasonable to assume we'll have found those efficiencies now? And the more that I keep asking this question and not getting an answer, the more concerned I am that things are being hidden deliberately or by accident from me. And then because the number included in the consultation leaflet and papers that we're seeing today is less than half of what we'd known about before, please can someone clear it up for me? Thank you.
Okay, well, you'll be delighted to know, Councillor, that you won't be getting an answer from me on this. I've had one go and I'm not sure I made it better. I think I might have made it worse, so I'm really sorry about that. Believe it or not, there is a real consistency to this, but I think perhaps I need to pass to a colleague to have a go at trying to explain that. So I think it's probably Mark, but shall I ask Mark to go with this and see if you're able to communicate it? I kind of get it, but I seem unable to explain it. So maybe you'll have more success. So over to you, Mark, if I can.
Yeah, thank you. And I'm sorry, Melissa, if you've sorry, Councillor, if you feel like you've been led astray. You've got my number. You can always call if you want to kind of me to talk you through it. But this is the story. Essentially, we've got 2,033 beds at the moment. Got that? That will increase through the lifetime of the plan to 2,172 beds, meaning we'll have 139 extra beds based on what we've got at the moment. The way we'll get those extra beds is 41 of them will come through converting some non-clinical space into clinical space. So the history of the NHS is sometimes clinical space that isn't needed gets converted into offices for consultants and nurses and sisters. Will convert that back into clinical space. 28 of those beds will come from repatriating our rehab patients that we have currently in hospital back out into the community. So we will no longer be doing rehab in the hospital, because actually, why would you? And that means we've got acute admitting capacity on what's called the Hampton Suite. That gets us 28 extra beds. Mm-hmm. And the rest of the beds, which is 70, will come through new build. Now, that new build in the pre-consultation business case that you've been looking at was originally going to be funded out of CRL, which is essentially NHS jargon for the money we get from government every year to spend on capital. I think what we're going to be doing as we approach the full business case, which will be sometime next year, once we've got through consultation and the rest of it, is saying to government, actually, that money should go in at the start and we'll fund it from the start. Because I think we've moved in our thinking from saying we might need those 70 beds to actually we're going to build it right from the start. And if we don't need them, then we'll mothball them. So headlines are 2,033 at the moment. At the end of the plan, we'll have 2,172. That is an increase of 139 physical beds. The bit you were asking about efficiencies is essentially, as you've heard me speak before, Councillor March, we currently do things on a daily basis that means we don't always utilise our beds as well as we could do. COVID has shown as an example that actually we have at any day of the week, sometimes between 30 and 40 patients who are medically fit for discharge, but because we're not quite working in a system as effectively as we could, they languish in our beds for a couple of days longer. That can take up whole wards at some point. So by improving things like that, or increasing, as an example, something we've just done recently, the numbers of consultants on our cardiology wards, it means they can do more ward rounds more often, which means they're able to discharge more often. And all those kind of things, they're badged under efficiencies. But really what it means is we just continually improve our model of care so that patients don't stay in hospital longer than they need to.
So
I just come in to add a little bit in that as well, please. So just to add to that, of course, there's also, we have the opportunity in the NHS to benchmark ourselves against all other trusts. And one of the key things that we really want to do is make sure we are at the upper quartile of efficiency. So there's opportunities within day case procedures, new ways of working from a clinical point of view. So not the discharge end, but actually in the acute end, in the way that we do operations that will actually support shorter stays in hospitals. And we want to be right in the cutting edge of those. So a lot of that is in orthopedics, a lot of more simple operations, but even some of the most complex cases, actually, if you optimise patients before they go into theatre, you then get them discharged in a better, improved timescale. So we want to have all of those really important transformational changes take place as part of this programme, and we've already got some of those started. So what we're not doing is saying, oh, we're going to start those when the buildings come. We've got to start those now, each year going forward, so that we're really driving those efficiencies or improved clinical pathways. Efficiency is a funny word, isn't it? And it can mean so many different things in lots of different settings.
Yeah, thanks, Rebecca.
So just to clarify then, again, because I've been asking about this at every meeting since I got elected, I think, because and that seems a really long time of 18 months now. But when we looked at this and we did the how many beds do we need analysis, there was a need for 300 more beds by 2023. Now it's 2020. In 3 years' time, we're going to need 300 more beds, and it's great that we're upping to. And I really welcome exactly what Mark was saying about putting for the 70 in the business case for now. But it's because those beds already exist, don't they? 28 of them, somebody suggested. So they're already encountered in that. I think my worry is we know our population is ageing. We know this is a really special, and that people are spending longer in hospital with more complex needs. We know this is such a one-off opportunity, as everybody has stated, and yet my maths of 300 take away the 139. That's less than half, but where are the other 161 that we need in 3 years' time? It doesn't. I'm really concerned that we're accidentally being a bit short-sighted in this, and that whilst I understand that there are efficiencies and improvements in all the different ways that you're talking about, I'm also concerned that if we continue to face, for example, more hospital cuts or less Better Care Together funding or other changes that that are seismic in how we work compared to 10 years ago, let alone 50 years time, I'm very concerned that we aren't building enough for the population as it grows and as its needs increase. So that's why I keep banging on about this figure of beds, and 139 beds for £450 million. I'm struggling to kind of square that circle. It seems expensive, although I'd really welcome the funding and all the things that come with it for the city that you're all talking about. Thank you.
Yeah, it's the 300, isn't it? Yeah.
It's not 300 though, is it, Chair?
I think there's a couple of things that might be worth saying. I think that the first thing we need to say, and it may be the correct way to do this, would be, because I know how important this is to you, perhaps the thing we ought to do is arrange for you to sit down with the team and actually really work through the detail of how the calculations were made. And because I think we try repeatedly to offer you the level of assurance you're looking for. We're clearly not. So, the work has been done, and maybe perhaps directly with Mark, you could pick that conversation up and work that through. And we're happy to kind of share and that as widely as we can. Couple of other things to say, if I might. The point Mark made about getting the bed number right is really important. And what we've tried to do through the 300 analysis is show how the future demand for beds grows because of changes in population, but is then mitigated by changes in clinical practice. That leaves a net requirement, and the net requirement is the one that we're addressing, the figure that Mark described. The second thing to say is that the 28 beds you mentioned are not currently counted in quite the way you think, because they're used for a different purpose. So we're repurposing. So they're 28 additional beds. They're not rebadged. They're different. And that's because we're doing something called home care first approaches, where we're looking to rehabilitate people in non-hospital settings. And we're doing that not to try and save beds. We're doing that because we get really much better outcomes. It's really difficult to have a genuine assessment of someone's ability for independent living when they're hospitalised. So we need a different approach. And again, really happy to talk in a different context about why that approach is there and how we're trying to modernise our approach to rehabilitation. But we see that as a really positive thing. And then the final thing to say is that it would be, although it's a natural conclusion because we talk about beds endlessly in the NHS, this isn't £450 million for 139 or 170 beds, whatever. It's £450 million to completely modernise a whole range of services. So it's not just about the beds. In fact, the beds are an important component, but the way in which we change adjacencies of service, the way we separate elective and emergency, the development of the ITU capacity, those elements are every bit as important and potentially as impactful as the bed numbers. So, I just wanted to, and I kind of know you know that, but I just wanted to make that point so that it doesn't seem as though, this is just a small development of a couple of wards that's going to cost 450 million. It's a much bigger range of transformations than that. I hope that just provides some explanation as to why it's structured in the way that it is. I may have failed again, Councillor Marsh. Every time I explain something, I realise I tend to make it worse rather than better, but I'm genuinely trying to.
I understand that, and what I think is clear in the comments bar is that whilst I do keep banging on about this, and sometimes facetiously, because I can do the maths and the numbers, but actually it's not just me, because look at everybody else saying yes please, yes please, yes please. People want to understand the nub of this issue and the basis of that. So I think a few of us would really welcome that briefing. Thank you.
Yeah, thank you.
And the ability to make that public to people who are asking us that this is a hot topic for an awful lot of people, and it is far more followed than the other scrutiny stuff that I do.
Yeah, thank you very much. We'll follow that up and act on that. I think I absolutely recognise that, so thank you.
Yes, Mark's already put it on the thing about how to contact him, so that'd be great. Thanks very much. Rosita, you're next.
Thank you, Chairman. I very much welcome an investment and brand new hospitals. I think it's the way to the future, and it is a good strategic position to be in, being mindful of all of the future development and the changes in society. And some of my questions are already partly answered. My question was going to be, have all of the plans been future-proofed past 2023? Because with new developments on the horizon, I know we're having a debate over 300 beds, but will that be sustainable in the long run, say in 20 years' time? So the question is, are the services future-proofed? And have there been risk assessments to alternative strategies if things change? So that is mainly one of the questions. The other question I have got, it is in relation to Councillor Waller. She was talking about the wider community provisions. To me, that is very, very important too, and I'm looking forward to see something on that, because what I'm constantly getting from my community, from bodies like Age Concern, it is that residents are really worried that we're talking wider community provisions, but they don't know what it is and they can't see that panning out, because one of the difficulties I'm having, it is that residents do not have access to the GP services now, especially when they need the reassurance for their mental health and whatever. So they're saying, what's the point of a new hospital if I can't even see my GP? So I think a community provision, how they pan out and how they relate to all of this is very, very important. What I'm mainly interested is in, we are talking what will be. But what I don't understand, it is when will it's a time frame, when will all of this be in place and actually, operational? And what are the plans whilst construction is taking place? Because I recall on a personal level, many years ago, when I went into the Royal for a procedure, I was walking through dust and plastic tunnels and following, diversion signs. So what are the plans to provide effective, efficient, safe services while all of this construction is in place? Thank you.
Good point.
Thank you. So there's three kind of distinct elements. I mean, you asked a range of questions, but for me, they grouped into three areas. One was the kind of future proofing of the plans, and maybe I'll just ask Mark to say a little bit about that. There was the wider provision, and I'll say a bit about that if I might. And then there's the really important issue of actually how do you build a hospital on a hospital site, and what does that look like, and how do you manage that? And I might just ask Rebecca perhaps to say a little bit about that, because we may not be able to kind of share with you all of the detail, but there is a really detailed program plan with phasing, and Rebecca might just want to describe a little bit of that. But if I can just start on this wider community provisions issue, I think one of the things that I'm really keen to stress here, I think, is that our investment strategy over the coming years, the amount of money we expect to get growth money year on year. We expect to commit that money to a range of mental health and primary care services. Some of that thinking we have already got detailed, so we know specifically where it's going to go, like Home First and those sorts of things. Some of it we know the amounts we want to commit, but we haven't yet got the detailed plans because we're trying to grow them bottom up with primary care networks. So what I can do is increasingly share with you that process, but I need to do that almost as a separate discussion, because although it clearly iterates with this, it is distinct in its own right. What I would say is that the plans to do that are fundamentally based on an understanding that we can improve efficiency of spend in secondary care. At the moment, the system, and we all feel this, so I'm saying these things openly with Rebecca here as well, and Rebecca, Angela and I as the three chief execs, we've looked carefully and we understand that we've got the balance of the system slightly wrong. Only at the margins, but we're spending just a little bit more than we would ideally want on secondary care, and that's partly because some of that's running with the structural inefficiencies of the three-site model and the difficulties that causes. We haven't yet committed quite as much as we would like to mental health, although we heard from Gordon, that position is changing actually, and even in the space of the last 12 months, there's really positive news there about investment and development. But the big area probably is to think more about how we work with the kind of community primary care. I mean, I pick up the challenge particularly about primary care access, so perhaps that's an issue we can circle around to. We've got clear plans, but we still it seems regularly to fall short of patient and public expectation about access to primary care. So I'd quite like to have that as another conversation, perhaps, because I think it warrants a conversation in its own right, but we have got development plans. Hang
on, if we could please, I think that would be really good, because I think that was something Councillor Waller also raised, and I think a lot of us who are in rural areas, and we would really appreciate that if the chairman can put that on the agenda. And while I'm on this, I don't want to be parochial, but if I may please, I very much would have to ask a parochial question. Why are community hospitals not included in this consultation? Now, I probably know what the answer is, but I just need your reply to that for the record.
Okay.
So, thank you.
Okay, so the community hospital provision is complementary to but distinct from the acute provision. So the reason we've organised it in this way is that whatever we do with community hospitals, we need to make these structural changes in the way in which acute services run. They stand on their own merit. And it's really important that we press on with this opportunity to modernise them, because no configuration of community services or community hospitals, for that matter, can work if there are structural inefficiencies in the way in which acute hospitals work. So we must address those, come what may. And I think it's the sincere belief, all of us, certainly my personal view, that these proposals stand on their own merits, and I wouldn't want them to get confused or slowed down, even though I understand why people are keen to link them with a wider debate, because we could end up where, you know, if we don't plan everything, we can't change anything. And I think the case for change here is overwhelmingly clear. So I don't want to kind of slow play it. That doesn't mean that the community discussion isn't right. And I think if I might just, Chairman, I know I'm digressing very slightly, but I just want to take this moment because it's something I believe really strongly in. Up until this point, up until I arrived, I think we had started a consultation process, or at least an engagement process about community hospitals, which I think was slightly in the wrong headspace. And I think you know this, guys, because we've had this conversation. I don't think we need a community hospitals plan for LLR. I think we need plans for the places where people live, of which the role of the community hospital is part. So we need a plan for Lutterworth. We need a plan for Melton. We need a plan for Charlingwood, for Loughborough. We need a plan for Hinckley. And community hospitals are not a generic resource in that sense. I don't think if you were to say, look, I've put all the community hospital beds into a big lump, worked out how many we need across the whole of LLR, and I'm just going to kind of throw a dice and work out which sites get which beds. That doesn't work. They're not that type of resource. So I'm really keen to have a different conversation, place by place, town by town, community by community, to say, what do we actually need in Lutterworth? What do we need in Harborough? What do we need in Oakham? What do we, what is the plan for that place? And then what role does the community hospital, or indeed anything else for that matter, in that community play in meeting those needs? I think that will give us a much, much better outcome than me having a master plan for community hospitals across the whole of LLR. So it's a different approach. I really believe passionately in it. I think it's absolutely right. And I want to get the space to do that work with communities place by place over the coming months. Whatever we do in that space, these proposals for acute services must happen, in my view. They're so important. The opportunity is so great that I want to crack on with that in the meantime. So that's why it is the way that it is. And I hope that genuinely explains why I'm trying not to kind of end up in a place where we don't do one great thing because we're not quite up to speed with another thing that, we've got to get that right. So I've rabbited on a bit, sorry, but Mark, there were still issues of future-proofing and then the sequencing. So perhaps, Mark?
A really interesting question, Councillor Page. So is it future-proofed? Well, the honest answer, it's future-proof to the extent that we can predict the future. And if that sounds like a glib response, it's not meant to be. It's supposed to be honest. So who would have known 9 months, 10 months ago now, actually, because the first case in China was 10 months ago. Who would have known that we'd be dealing with a worldwide pandemic? The kind of things we have in our heads when we're thinking about what future hospitals look like are things like, what will the role of robotic surgery be like in 5 years' time? Currently, we have one robot in Leicester's hospitals. That is likely to increase because you can do more precision surgery and medicine as a consequence of that. Another question is, what is the role of artificial intelligence in terms of supporting both consultants and GPs to make clinical decisions, given that the body of knowledge that any consultant or GP or nurse is expected to carry around with them now has grown so exponentially that they can't know everything. What is the impact on multi-resistant organisms going to be? You know, there are a couple of organisms doing the rounds at the moment that there is only one antibiotic left that nails them. And in time, that antibiotic will become less and less effective. The way we are designing and planning the hospitals has all that in mind. So, for an example, on multi-resistant organisms and pandemic, it's about how do we build light switches that don't need to be touched, or door handles you can open with an elbow, that kind of thing. But anybody who says their hospitals are future-proof beyond 10, 15, 20 years, I think is living in a dream world, because we don't know what's going to happen in 10, 15, 20 years. We don't know what cures are coming down the road. We don't know where the kind of work that we're doing at Leicester University around genetic mapping and genomic medicine goes. So what we try and do is build our best anticipatory case, but make it flexible in a way that actually we can cope with what the future throws at us. So an example of that is one of the reasons why the Glenfield site is a good site for investment, is actually most of the Glenfield site is on a single story level. So there is the ability to go up more and more at the Glenfield, subject to our colleagues in planning, if that were required. And indeed, that's what we did prior to COVID on the interim intensive care expansion, was we put more intensive care facilities on top of existing wards. So it's maybe not the answer you were looking for, but it is at least honest. We are future-proof to the extent we can predict the future.
I accept that, but what about, and you don't have to do it now, but if you can work that in your discussion in relation to the beds, I mean, we are talking, you know, will those beds, and have they been taken into consideration, the pending, all of the planning, for instance, 2,500 houses in Lutterworth, 2,000 houses in Scraptoff, you know, Lubberthorpe, because as this is growing, and if you're looking at the strategic growth plan, because we are talking virtually in our area, population expansion to extremes. So, and like I say, you don't have to go into details now, but just, you know, the beds, will they be will they be efficient enough to cope with it, even if you're taking in consideration new working methods and whatever else?
So population growth, epidemiology, disease likelihood, birth rates, all those things inform the bed model. So the answer is yes.
Okay.
But we you know, people want absolute certainty, and health and healthcare and the NHS, as COVID has proven, is part art and part science.
Yeah.
And we are as certain as we can be that it's right, but we also know that if push comes to shove and we need more beds in 5 years' time, we'll have to create them. I would see that as a failure, by the way, because it would mean we are perpetuating the model where big acute hospitals get bigger and bigger and bigger. I think there's another way, but if we need them, we will have to build them.
Thanks, Mark. Fair.
Just briefly to
my last part of the question, the construction.
Yeah.
Just
Should I pick that up?
Yep.
So thank you very much. This is a really interesting question. And I think one that, if you look at University Hospitals of Leicester over the last few years, actually have done this very well. So we've had a number of reconfigurations of our services, practically moving over to the Glenfield, putting on additional ITU at the Glenfield site, etc. And we've been able to keep our patients environmentally safe. It's a really important issue, particularly with some of the most, you know, You know, it's really important that we're keeping dust levels, etc., down. We've got a great IPC team that works with us, so our infection prevention control team. We've got some great experts, and we've got experts that we are using to support the reconfiguration very closely. So we've got additional support put into the team to help us with that. The detail of the design and the detail of how we will transition through construction, we won't have yet. We won't have until we've done that real detailed design level. But I think we've got a good proven track record on this, and we just need to keep very close, because our safety of our patients during these builds are very, very important. But a very, very good question, Councillor, and one that I will actually be just questioning a little bit more myself. So thank you for that.
You're welcome, but just to come back, so I assume once you know where you're going with the outcome of the consultation, etc., then there will be a construction plan in place that you will be working separately on, which includes parking and all, you know, from the basis to patient care. So just to come back, what are the timelines you see for all of this, so to get us some idea? And I know that is how long is a piece of string, but it would be nice to have some sort of idea.
I'm just going to ask my colleague Nikki, who's also on the call. Nikki Topham is the director leading our reconfiguration team, and she's on the call. I'm just going to ask if she can come in with those timescales. And again, you're right, there is going to have to be some give or take with this because of consultation, etc.
Yes, thank you. So I'll just respond to the timescales. It's quite a complex programme. I think, as Mark identified when he was showing the slides, particularly of the Royal, the fact we have to do one set of buildings before we can do a next set. So we've got a complicated plan which takes us over the next 7 or so years. So pending the outcome of consultation, after Christmas, we'll be looking to start some detailed design. And in order to draw down the money, we have to do business cases. So we have something called an outline business case and a full business case. Each of those cases takes about 9 months each. So we're looking to start the major construction in about 18 months' time. Now that will be on the LRI site. Once consultation's complete, the NHS are open to us doing some enabling works, and that would include, for example, early car parks to get the sites ready for that construction programme. The 2 big new builds that you looked at the Royal in Glenfield will deliver towards the back end of 2024. And then the next 2 or 3 years, a couple of years later, we'll be able to deliver the Children's Hospital, and then we'll be doing the final sort of retained estate refurbishment on adults' beds. And that's because children need to come out of the main building blocks at the Royal in order to then upgrade those wards to become adult wards. So it's quite a complicated and convoluted process, but we are scheduled to do that in 7 years.
Thanks, very helpful. Thanks, Nick.
Chairman, can you indulge me one question? Now, we're talking outcome on the consultation. Now, to make it a meaningful consultation, you analyse all of the comments. So say, for instance, as a planning authority, when we consult, we collate all the comments, then we say they have been taken on board, they can't be taken on board, and it lengthens the process. So how do you see, and I'm honestly finished after this, how do you see, how you're going to evaluate the comments, take them on board, and how do you see, will it make a difference as such in the outcomes, if there's anything that comes out that is of major significance that then could delay your plans? So just a general idea on that, and I thank you all for your comments.
And patience.
So just to pick that up, we went out to an open procurement and invited a range of organisations, including academic universities, to submit proposals to help evaluate this, because it's something we don't do ourselves. We're too close to it, so we commission that as the CCG. That process culminated in us commissioning the commissioning support unit, which is an independent organisation to us, to do that work. work. They will evaluate all of the responses and give us the report, which will be in the public domain. And that report is given to us. It's not amenable to our interference, if you know what I mean. They will conclude what they conclude and report the outcomes. Broadly speaking, these sorts of consultation processes tend to answer three questions, really. That there may be some things where we specifically have asked for a response, and we'll use that to decide what to do. So, to what extent, for example, we talked earlier about the standalone midwifery unit. What's the reaction to that, and how does that help us then make a final decision? What about the range of primary care services on the general site? What should that look like? So that's one type of response. The second thing will be we'll often get kind of, well, these proposals are okay, but what about this? What about that? We talked about transport, so that might help us hone in on issues that we need to address in order to make the implementation successful. So they wouldn't change our mind about whether to do it or not, but they might change our mind about how to do it and what sort of issues we need to address going forward. And I suspect we'll get quite a lot from the consultation on that. We usually do, and that will change the way we go about potentially implementing or standing up some of these processes. Very occasionally, you get some feedback from the consultation which is of such purport, because it raises an issue that we hadn't thought of, or it shows a level of reaction we hadn't anticipated, that it causes you to fundamentally rethink about aspects of the plan. So either the timing or the sequencing, or even aspects of whether you go ahead or not. That's reasonably rare, because the process the NHS goes through before it authorises a consultation means that most of those fundamental issues should have been worked through before the consultation starts. The NHS has a whole series of gateways that you have to pass before you can initiate a public consultation to make sure that it's not just a silly idea, that there is real merit and has been engagement to this point. But it is possible. So we're open and expect to see feedback on all of those areas. The most likely thing is, I think we'll get feedback on some aspects of questions we've asked and some aspects of implementation, the how plan, if you like. But it is possible that there may be things in there that cause us to have a more fundamental rethink. Until we see the detail of the consultation, of course, we won't know, but we will share all of that openly, and you'll be able to see not just who said what, but how we've interpreted it and what that's led us to conclude in reaching final decisions.
Yeah, thanks very much, Andy. Before you joined us, I think, we had some questions from members of the public, some of which were answered by the previous reports that we've had. But there was one particular one that applies exactly to what you've just been talking about. And I don't know if she's still on the line. Jelana Foster, you had a supplementary, I gather, on the use of an external consultancy. Are you still on?
Yes, I'm still here.
Sorry you had to wait so long.
That's all right.
Would you like to ask your, I appreciate that it's been a long time, but it's the way the system works. Yep.
Yes, yeah. I mean, my question was to go over it again.
Well, it's supplementary we need, not your
Yeah, sorry. The supplementary question was that I didn't feel that my question had been answered sufficiently the first time. It's about the independence of the analysis. Midlands and Lancashire Commissioning Support Unit is a paid contractor to local CCGs, and I don't see how they are independent. Please, could you tell me how they are?
Right.
Okay, so they're independent to the extent that they are subject to completely separate governance. We have no authority or influence over them. We can commission them to do work on our behalf, and we do, but we have no more authority over them than we would say over an independent management consultancy or over a university department. So they will accept a job from us, which they've done. They bid for and won this procurement, but we have no managerial authority over them. We have no governance authority over their board. None of our members or any of the executive directors, myself included, have any authority inside that organisation, and they have no accountability to us beyond that which we've established through the letting of the agreement. So they are independent to that extent. They are part of a wider NHS family. But even then, CSUs are distinct from other NHS organisations in that they report up entirely differently through the structure of the NHS. So they're not accountable to our regional office, they're not accountable to Dale, they're not accountable to the same people as me. They have an entirely different governance structure which only touches at the very most senior level of the NHS. It's Simon Stevens, basically. But beneath that, they have a totally separate governance route. So they are as independent from the CCG or UHL or LPT as any university or the commercial organisation could be, really. And we won't be working with people that we know well. So these aren't my mates I've let the contract to. They're not colleagues or people I work with day in, day out. It's a different team, and they will be bringing a genuinely objective perspective to this process. We would have tested that, and we did test that through the procurement process, because of course there's no point in bringing this in if we're going to get a view that we already kind of understood and knew. So we were careful to make sure that this would be a genuinely objective process. So I hope that helps, but I'm not sure if that touches on the issues you were particularly concerned about, but that's how I would explain it, I think.
Yeah, well, we don't allow, that, please? No, you can't, because we don't allow discussion. Sorry about that. However, clearly you can raise this obviously through the consultation fully. We've heard what you said. We as a scrutiny body can clearly obviously take that up as well. But I think the answer you've had is fairly clear. It's standard throughout all, not just the NHS, but that people do use as external organisations. But you obviously, there's a specific point you've got, then I suggest you raise it directly with the CCGs. That'd be the best way of doing it. And then you get a specific.
And I'm really happy to, if you want to drop me a line separately offline, or you want to understand that process in a bit more detail, I'd be really happy to kind of respond. So just drop me an email or get in touch with me through the Scrutiny office. They've got my contact information, and I'll happily do my best to provide you with further information.
I think that's the easiest way on this. Thank you very much. I've got, apart from, I appreciate still, I don't know if she's still on the line, we've still got Sally Ruane waiting. I've got just two more people want to ask questions. Amanda Hack, I don't know whether you wanted to ask it or whether you were prepared to just do it online with Mark directly. Amanda? Gone. Right.
Sorry. Apologies. Yeah, no, my question was just more about just the science behind the modelling. So I'll go directly to Mark on that. Thank you.
Thanks very much. Janet Underwood.
Thank you. It's really picking up on Andy's emphasis on place and the consultation that we're now in. Why can't we have place-specific consultation events, i.e. a Rutland one or a Melton Mowbray one, etc., as we've had before, and which we have requested, and we've not received any real reply for why we can't have one. I would also like to know how you're going to compensate for the fact that the population of Rutland is only 40,000 compared to 1 million plus in Leicestershire and Leicester. So statistically, the responses from Rutland are going to be overwhelmed by the responses from Leicester and Leicestershire. And then finally, will the public or councillors or Health Watch be able to see the breakdown of the statistics and the results of the survey for each area, so we get a better picture of what, say, Rutland wants compared to with what Leicester City wants? Thank you.
Yeah, thank you. So just working through those issues, in a traditional consultation environment where perhaps we would have worked, even in the relatively recent past, we tended to try and organise a series of public-facing events with a kind of geographical access in mind. And so it made sense to do that, didn't it? Because obviously different people will attend different events depending on their proximity. In an environment as we are, where we're doing a lot of virtual consultation events, that feels a little less relevant, to be honest, because people can dial in from wherever they're at. And I think we didn't want to kind of preclude access. So we've said, look, we'll open up as many events as we can to as many people as we can. I think if through this consultation you feel that there is a perspective that's being lost, particularly from a Health Watch point of view, then please speak to Richard and myself. And we are moderating this consultation in real time. Every day we look at the results we're getting back, and so if it's clear that Rutland just isn't getting a say, or our responses aren't coming in from that area, or we're missing an age group or an ethnicity or a particular town, then we'll look to adjust that. If that's your sense too, then please speak to us, and we can always modify the process, and we're really open to that. So we will try and run events that face a particular way or try and engage a particular community. In terms of the of how do you stop voices getting drowned out, how do you stop the aggregation obscuring particular communities or particular ethnicities or particular age groups, then we've explicitly asked for the results to be analysed in a way that would prevent that. So we will be able to tell whether young people have participated or not, whether Asian people or Black people have participated, whether or not elderly people have participated. And geographically as well, we've got a skewed results. It's all about the city, and we haven't got a view from the wider parts of the county or from Rutland, or vice versa. So we can look at that. We've asked for that analysis, and again, we'll share that, openly. I don't think the intention is to hide that, really. And it's entirely possible, actually, that proposals like this may be broadly supported generally, but there are particular issues for certain groups of people that we have to think carefully about at implementation. So this may be great generally, but what about people who live right next to where some of the building work's going to be done? Or this may be great generally, but what if you're in the 30% of people who've got further to travel? How's that actually going to work for you? So we need to understand that, and we will show that. It isn't always possible in consultation to accommodate every perspective. Sometimes a change has a downside you can't mitigate, and then you've got to make a judgment about whether it's in the kind of interests of the greater good or not. But that doesn't mean that we won't be able to identify in detail what people have said or how this impacts. And that feedback will help us think about implementation approaches, mitigation strategies, risk management. So absolutely, we'll be able to look at it. Absolutely, we'll share that openly. We want these plans to be brilliant, and we want this consultation to be the best of its kind. And your help in doing that is essential, and you can't help us if we're not honest with you. So we will share everything we possibly can without breaching people's confidentialities, of course. But we'll share that as openly as we can, and look for your help and engagement to make this a really great consultation process. That's our commitment, really.
Thank you.
Yeah, thanks very much, Andy. That's very helpful. I don't know if she's online still. Sally Rowan, I know you had questions about bed numbers. We've had lots of talk about bed numbers, but I don't know whether you're still online.
Thank you.
Yes,
thank
you are.
Councillor Fells. Thank you very much. Yes, I was listening to the earlier discussion, but I think the 28 still remains up for dispute here, because the Hampton Suite beds are actually included in the bed efficiencies in the appendix to the PCBC. And also, if you ask UHL to list all of their beds by ward, they will include the Hampton Suite. So I can't see why suddenly these 28 beds didn't appear in the 2033 baseline beds that you said that you had in 2019. So I suppose to clarify, so they still look to me like the reuse of existing beds and not additional beds. In other words, it still looks to me as if we've got a maximum of 111 additional beds and not a maximum of 139 additional beds. So if they are categorically not counted in the 2033 categorically, then it would be useful to hear that. And my supplementary then was about where the 70 contingent beds will go. There's been some discussion today, and I think Mark mentioned maybe getting capital funding up front. Not a definite commitment, but that possibly this will happen, to building those. So where will they actually fit in? Because it seems to me that the Royal is completely jam-packed once everything has been put onto it. So it'd be interesting to know where they're going to go. And also, the 41 beds which are going to be made possible by converting non-clinical space into clinical space, is the money for that coming out of the 450 million? I just can't tell from the documents that we've got. Thank you.
Thank you. Every time I answer these questions, I think I make it worse. So I'm definitely Mark, and on the basis that I don't seem to be able to convey this very well. So Mark, can I pass to you, and hopefully you can do a better fist of it than I've been able to.
Well, to be honest, Andy, I clearly can't, because no matter how many times I try and explain it, and even though it's written down in the PCBC, it's still not getting through. So the first thing to know about the Hampton Suite is they whilst they are beds, it was a ward that was an acute medical ward. We don't admit to the Hampton Suite, so we don't admit acute medical patients to the Hampton Suite. What I mean by that, Sally, and you'll know this, in fact, I've offered before to show you around our acute medical wards, is the Hampton Suite is a step-down subacute ward that was put in place to substitute for there not being community provision for that cohort of patients. Therefore, when we take patients to the Hampton Suite, we're taking them from our acute medical wards and putting them there before they are discharged either back home or into a community hospital bed. When the Hampton Suite converts to an acute medical ward, it will have admitting capacity, which means it goes into our bed capacity. In terms of where the extra 70 or so beds go, broadly at the Glenfield and at the Royal, but until we've done the full business case, which is sometime next year, we're not able, and I'm not willing to put exactly what the split of that will be, because we're still working it through with our clinical teams in terms of, okay, so renal will need 18 beds or they might need 16 beds. But broadly, the extra beds will go into the Glenfield and the Royal Infirmary. Final point, you say the Royal Infirmary is full to the gunnels. Well, yeah, it is now. But as you know from previous conversations and when you've been in and seen me and John and others beforehand, John being John Adler, our previous chief exec, part of this plan decongests the Royal Infirmary. So rough numbers, don't quote me on this because they change on a daily basis. The Royal sees about 740,000 patient contacts a year at the moment. At the end of the lifetime of this plan, that number of patient contacts will drop to somewhere in the region of 390,000. So as we said all along, part of the upside of this plan that isn't necessarily about health is actually in decongesting a city centre site. There are other kind of societal benefits to it. So that's it. Thank you, Chair.
Yeah, and as I say, we have got, I think, and it's important to do this. We clearly need to sit down with a group of interested colleagues and run the bed model through, because clearly people are really interested in and to some extent concerned about this as well. So, in answering those questions comprehensively, we'll hopefully answer not just the people who are now expressing that view, but the many other hundreds who probably are glad these questions are being asked. So we'll do that for definite, and with colleagues' agreement, we'll use that actually as part of our consultation and engagement, because I think what we want to do is to make sure we've got this right, really. And if we have, great. And if it's not right and we do need to modify it as a result of consultation, then of course we will. But let's put it under that level of test and really make sure that we're comfortable.
Yeah, I think that makes a lot of sense. Thank you very much, Andy. No, I mean, it's clearly for many people, and not just Sally and many of the members today, there's a lot of people are still worried about bed numbers. It sounds an awful lot, 2,172 beds. But I just said in one of the chats just now, I visited a hospital which had 3,000 beds, and that was 25 years ago down in South Africa, largest hospital in the Southern Hemisphere. One has to think forwards. But thanks for that, Sally. I have no other, as far as I can see, no other questions. So bringing it all to a close, really very fantastic. Thanks to obviously Andy, Mark, Rebecca, and indeed Nikki, who joined in, and thank you to all of the members that stayed for the 4 hours we've been on, near enough. But apart from me, because of course I was whizzing about trying to get onto the system for about 10 minutes. And thank you very much to Patrick, who held the fort for a while. We are meeting again as a joint health overview scrutiny committee on the 21st of September. No, on the 14th, beg pardon, which is obviously a week before the consultation ends. So it gives us another bite of the cherry. And obviously also at that point, we may have our own views. But that is the point, of course. Please, all of you, make a point of actually joining in on the consultation. It's there for everybody. There are lots of events. I've spotted them all coming through on social media. I tried to join on one the other day and then got called to the front door, and that was that. But I think that's the point. We need to be sure and spread the word. We need as many people as possible. And the 8-page document that Richard's, thank you, Richard, as well. The 8-page document that Richard talked about, I've not had it yet. So it obviously still doing the rounds, but it'll get here eventually. And I think it's been a good discussion today. We've had a lot to talk about, a lot of discussion, and I just thank everybody that's been part of it. So that's the end of that particular item. Therefore, moving on to item 10, which is the date of the next meeting. I've already dropped it in the hint. The next meeting of the committee is scheduled to take place on the 14th of December 2020. There will be some follow-up to obviously this particular meeting, one of which I think is that we, thanks very much for your offer, Andy, we probably do need to have a bit more of a rethink on how we put forward to the people, but also to the committee, the bed modelling and where we get numbers from, because clearly you can have numbers double numbered, all sorts of things. But I'll talk that through with you, and we'll see what we can do for that. But thank you very much, everybody. It is near enough 4 hours. You can go and have your lunch now if you're not missing.
We're going to call straight off. We're slightly overdue to go and talk to the city mayor, so we're going to call off and take our roadshow on to the next.
Blame me, he's used to it. Bye.
Thank you, everyone.
Thanks.
Take care.
Thanks very much, everybody.
Bye-bye.
Thank you very much.